be capable of repeated viewing. Do any members present today wish to declare an interest in relation to any matters included on the agenda? I don't see any indications. And now move on to exclusion of the press and public. The press and public won't be excluded from the first part of this meeting, as there are no confidential issues. I now ask committee if it's happy to agree the minutes of the Hove meeting that took place on the 19th of November 2025. All agreed. Thank you very much. I'd now like to give my communication to the committee. Firstly, we have a new member on HOSC today, and I'd like to welcome Councillor Ty Galvin, who will join the committee as an independent member. He replaces Councillor Bruno Di Oliveira. Welcome, Ty, and I hope you enjoy your time on this committee.
Thank you, Chair.
We're looking at some important issues today. I know that dentistry, and particularly the problems of being able to access an NHS dentist, is a matter of concern for people living in this city, as it is for people right across the country. We have a paper on dentistry presented by NHS Sussex, which commissions local NHS dental services. We're also joined by Sussex dental practitioners. We also have a paper on local health inequalities presented by NHS Sussex and by the Council's public health team. I'm sure members will be aware of the stark health inequalities we face locally, and will also be aware that this is a growing problem. We'll hear today about some of the work that has been done to tackle these inequalities. And finally, we have a presentation from NHS Sussex on the major changes that are taking place in the NHS, including progress on the merger of Sussex and Surrey Integrated Care Boards, and on the move to a more strategic approach to NHS commissioning. I note that there are no public questions on the agenda today, and there are no member questions. I'm now happy to move into the first substantial item on the agenda, number 24, dentistry. This paper provides an update on the actions being taken by NHS Sussex, the local dental commissioners, to improve access to city NHS dentistry services. We are joined today by Gary Money, NHS Sussex Director of Primary Care Commissioning, and by Ellie Coleman, NHS Sussex Senior Manager, Primary Care Commissioning. I'm pleased to say that we also have some dentists working locally who have found time to join us today. I'll begin by asking Gary to introduce them.
Thank you, Chair. I'll probably turn first, if that's okay, to Nish Sushak, who's the chair of our local dental committee, which represents all dentists. But Nish, did you want to introduce yourself and your
Thank you, Gary. Mr. Chair, thank you very much for inviting me again. I was at your last HOSC meeting in January 2024, so you didn't get bored with me then, so you got me again. I've brought along two colleagues of mine just to make sure they can just put some input as well. I've got my colleague Ali Mubarak, who's a general practitioner as well, and Aisha Asghari. I'm the chairman of East Sussex LDC. I'm also a principal dentist in practice working full time, and I'm also a foundation trainer. Thank you, Gary.
Thank you. I'm now quite open to Gary, if you want to make a short presentation, and I'll open the floor up to questions from members. Thank you.
Thanks very much, Chair. Yeah, we were very keen that, so Nish is a dentist in Hastings, which will be quite relevant to some of the areas we talk about, but in particular very grateful to his two colleagues who are local Brighton and Hove dentists. So obviously once we've finished, they may want to give their own reflections about the state of NHS dentistry. If it's okay, I'll assume that the paper's been read, but I was just going to draw out some of the key points, and obviously very pleased to be able to come along and talk to you today. I can't emphasise strongly enough that alongside access to other services such as general practice, access to NHS dentistry is an ongoing priority for NHS Sussex. And even with the merger with our neighbouring ICB in Surrey, I don't think that will change at all. In fact, I know that. So I think today is a good chance to say how have things moved on, if you like, since the last time we came to the committee in January 2024. And a lot has happened in that time. Whilst we've tried to make the paper major on Brighton and Hove, understandably, because that's what you and your constituents will be interested in, it is a particularly interesting time to be coming to present a paper. So we have taken the liberty to put in a little bit of stuff about national dental contract reform, which, if you remember the presentation back in 2024, for those who were at that, a lot of the issues that we have in the country around access to NHS dentistry are national. They are not unique to Sussex, and so that can generate quite a lot of frustration amongst local communities around understanding, well, what can be done locally versus waiting for a national solution to arrive. So very happy to take questions on that aspect when we come to it. Some of the things about the National Dental Contract Reform I'd probably draw out for you. So there has been a consultation that was held across the country. I don't know how many contributions were made by people in Brighton and Hove, but it was a public consultation. And that consultation has now led to some slightly amended recommendations. And as I say, local dental practitioners will give their own reflections about whether this will, quote, fix NHS dentistry or how big a change they think it is. Some of the big changes for us as an ICB it does change some of the incentives. And incentives are one of the big problems around making NHS dentistry attractive for people to provide it. Obviously, nobody wants to make a service that makes a loss. We do have a bit of a mixed economy in terms of private dentistry. So it's not run like general practice where, there needs to be, so particularly for patients with complex treatment or patients who need urgent treatment, at the moment, the previous incentives just weren't really working. Some of the things that are coming in from April onwards are there will be new ways of paying for complicated or complex care pathways and packages, which hopefully will mean that there's a bit more call and recall for patients who have sort of unmanaged progressive disease, so gum disease, etc. There will be a requirement for every single holder of an NHS dental contract, a mandatory dental contract, to provide a certain percentage of urgent dental activity, which is not the case at the moment. It's something like 8.2%, so it's very specific. And obviously each dental provider will have a different number of units of dental activity they're commissioned to deliver. But in total, what that means is rather than, and you'll note in the paper, there are lots of separate initiatives we've been trying in Sussex to try to mitigate or add to what is available nationally. This will be the first time some of that is baked into the national contract for anybody delivering dentistry, which I think is welcome. There's also a much greater focus on prevention, and again, we'll come on to it in a moment if that's okay, Chair. I'll ask my colleague Ellie to give a bit more update around some of the work we've been doing with the public health team at Brighton and Hove Council and others around supervised toothbrushing and some of the other initiatives. But generally, as you know, oral health is quite a strong measure when you're looking at health inequality. So it's good that we're on the same agenda as that paper as well. We are absolutely committed to trying to do more to get upstream with parents and with children to try to improve oral health at an earlier stage, because obviously otherwise you end up with, and clinicians will back me up on this when they come in, no doubt, much more progressed disease and worse health outcomes in terms of oral health. So happy to take questions on national dental contract reform. After that, we've got a section trying to give you the latest numbers. I know one of the biggest confusions people have is whereas you register with a GP and you're on the GP's list, that's not how dentistry works. And I know that is really counterintuitive to a lot of people who might remember the days where I know who my NHS dentist was and I get recalled every 6 months. And things are not quite like that at the moment. So we've put in the paper, but essentially anybody can access any NHS dentist. There's no boundary, there's no restrictions. So people can travel from Rye to go to a dentist in Brighton, should they wish to. Obviously there's a travel involved. Because Brighton is a bit of an epicentre at the centre of a health economy, there'll be lots of people who obviously come into Brighton to work and then they may travel back elsewhere. So who uses NHS dental services in Brighton will be quite interesting. At the moment, we've put in that we've got 43 what we would regard as dental contracts So technically, one provider can have more than one contract. So it's not quite the same as 43 GP practices, for example, but there are 43 NHS what we call high street dental contracts. In total, the total number of providers has actually dropped by one, because we've had 2 terminations and we've had 1 brand new practice that we secured in Hove. However, the total number of units of dental activity has gone up since last time. And that is a trend in Brighton and Hove along with the rest of Sussex, but sticking on Brighton and Hove, we are delivering more units of dental activity on the NHS in the city than we were previously, and we are continuing to see increases. We've put in the paper around some of the different initiatives that we've been trying, and I appreciate some of the language is probably quite arcane. So we've talked about temporary commissioning, we've talked about overperformance, and we've talked about procurement. I think the message is, and again, happy to answer questions on any of that, I think the message is that we have used every contractual lever as NHS Sussex, and we think we're one of the more proactive ICBs on this, to try to stimulate local NHS activity increases. So we've put in some figures in there. So without going through the detail now, one of our initiatives generated around 20,000 additional units of dental activity in Brighton. There's another 20-odd thousand units of dental activity in Brighton we've stimulated that's coming on stream now. And then we also have a further, I forget exactly how much of that going back to, but we have a third pot of UDAs which are coming on stream after April. And 10,000, thanks, Ellie. So we will continue to do that. So I can say that without hesitation. So we will continue, despite national contract reform, we will continue to use every single opportunity we have, as long as it's affordable within our NHS dental budget, to get as much NHS dental activity as we can in Brighton and Hove. But again, happy to discuss some of that. I think probably the last thing I would say is that there is a huge national focus on urgent dentistry. So there's a particular political commitment, without getting political, that talks about 700,000 units of urgent dental appointments. And there is a share of that for Sussex, so that's how NHS targets work. So we have 26,546 additional urgent dental appointments we have to deliver. Of course, good oral health is not just about urgent dentistry. And actually, probably some of what your constituents come to you with is about access to what you would consider routine dentistry or repeat dentistry, being called and recalled back. So I think at the moment what I would say is our strategic focus is on both. It's not just urgent dentistry. It's absolutely what we previously called stabilisation, where, for example, you might have a dental extraction or something, but then there's a course of treatment that needs to happen afterwards to try to stabilise the patient's oral health. But again, I'll defer to my clinical colleagues to say more. And the national contract reforms should make that more attractive in terms of doing that package of a series of appointments rather than just a one-off urgent dental appointment. If it's okay, I'm conscious of the time, I will turn to my colleague Ellie, who hopefully can say a bit more about urgent dental activity, specifically in Brighton and Hove, and then also some of our work with the local authority around paediatric oral health as well.
Yeah, thanks, Hove. So I was just going to touch on those 2 things because they're things that we have made quite good strides on over the last 2 years, and notably in Brighton and Hove. So for urgent dental care, if I go back to the beginning, back into 2024, when we first started working on NHS dental commissioning, we launched an urgent dental care and stabilisation pilot in Sussex, and it was largely very successful, and it aimed to basically provide additional appointments for people who didn't have a dentist and hadn't had an urgent dental care need. And it was very successful, so we've been running it since 2024, and it's now been expanded to 24 practices across Sussex, and 5 of those are based in Brighton and Hove, so I think it's 2 in Brighton, 3 in Hove, and those practices deliver currently over 200 extra urgent dental care appointments every single week, which is really positive. However, we did look back at it, so we weren't actually filling all of that capacity. Initially, it was only for patients who had a serious same-day urgent need, so if you woke up and you had pain, for example. But we weren't really maximising capacity that way, so we've now expanded that to urgent, unscheduled dental care. So now if anyone has unscheduled dental care need that isn't immediate and urgent and they don't have a dentist, they can call and be booked into those slots within 5 days. And that has been a bigger benefit for patients in Brighton and Hove, because if they called and all the appointments were filled, they can now get an appointment the next day or the day after, and we are consistently filling those slots now, which is really good. The second element of the scheme is there's a stabilisation element, as Gary's already mentioned, which is available for vulnerable patients. So those patients, they can still access, if they have an urgent issue, they can still access those appointments, but they can also go again for stabilisation appointments to stabilise their oral health, and that is available for looked after children, adults and children who are referred from adult social care, and clinically vulnerable patients. So, for example, patients who need to be orally fit before having cancer treatment, for example. So that's been a really positive change kind of locally. And then on top of that, as Gary's mentioned, there's a national target to achieve 700,000 additional urgent dental care appointments, and that's our 26,000 urgent care appointments that we're supposed to do every year. So on top of that, there's been an urgent dental care incentivisation scheme that was launched in September, and we had 50% of our dentists applied to deliver that, so they're allowed to deliver 25% extra urgent courses of treatment than they currently already do. And in Brighton and Hove, that worked out, there was 16 practices that were approved to do that. And so they can now deliver up, I think they're delivering about 7,000 additional urgent courses of treatment on top of the 200 extra appointments every week that are available in Brighton and Hove. So in terms of urgent access, it is something that has come along quite fast since 2024, but there's still a long way to go, but those appointments are getting really filled quite quickly and consistently now, which is a massive improvement. But the other thing I did want to speak about really briefly is the work that we've been working on for the last 6 months or so for increasing access for children, because you probably all know this, but there's the most common non-communicable disease for children is dental decay in England, and a lot of children, unfortunately, in Sussex and country-wide do have tooth extractions under the age of 10. So we worked really closely with our public health colleagues across the whole of Sussex, but in Brighton and Hove as well, to kind of pinpoint targeted areas of need. And we have now set up 16 pilot sites who are delivering we've called it the 0 to 3 Paediatric Access and Prevention Pilot, which is maybe not the most catchy title, but essentially there's two elements of it, and those practices that are participating, they have to be open to seeing new 0 to 3-year-olds, and then when they are seen, they're given a toothbrush and a toothpaste, their caries risk is assessed, and they're given some kind of basic prevention support. And then the second element is that prevention. So every practice that is participating in our pilot has been trained as an oral health champion, and any 0 to 3s who are seen through the service who have a high caries risk are being referred to that oral health champion, and they're doing liaising with their families to do investigations into diet, into behaviour change, and seeing if they can pinpoint why those 0 to 3s have such poor oral health and how they can change that. And then we're also funding those oral health champions to go out into their local communities and provide outreach at local nurseries, and to develop referral pathways from family hubs and GPs and early year settings, and just wherever, so we get as many in as possible. It's really early days, but we do have, so when we worked with our public health colleagues, we pinpointed Morscombe as a place in Brighton that needed targeted needs, so there's a site set up there. And I'm hoping Nish might have more to say about this later, because his practice in Rother is delivering the pilot as well. But it's really, really early days, but we've so far seen about 317 new 0 to 3s through the service, which is quite positive. It's a positive start, but we've got a long way to go still, and it's something we're going to keep working on as a priority.
Sorry, we couldn't work that out. So I think just drawing to a conclusion. So we've also put some stuff in there around, so there's something called a golden hello. So this new incentive scheme to try to attract new dentists into the area. Obviously, some of that key worker conversation will be familiar to you about how a city like Brighton and Hove can attract all of the right people in terms of quality of life, that they can have schooling for their children, you know, all the rest of it, recreational space. The Golden Hello scheme, we weren't successful with the first 2 Golden Hellos that we offered to Brighton and Hove. You might note in the paper we've gone back with 4 more. So we are hopeful that we can attract some more dentists in, and you'll note the period of time that they hopefully will be not bound, but will be wanting to work in the local area with the incentive. We've also put an example of the poster that we've been popularising. So obviously you have very good connections across your community. So hopefully you recognise the poster that we've put in there. If that's a surprise to you, then obviously we've been working with Health Watch, but again, we'll be looking to try to raise awareness of things like our NHS Sussex Dental Helpline, which is a line that anyone can call, which helps patients to book into appointments, particularly if it's around urgent dentistry. So I guess in conclusion, Chair, what I'd say is we're very glad to be invited back. Obviously, it's been a while since the last appearance. This isn't going anywhere as a strategic priority in Sussex, and for obvious reasons. Whilst we're quite calmly pleased with the progress we've made, we're not pretending that everybody can easily access an NHS dentist in the same way that all NHS services have got capacity limitations. But we have seen some genuine positive progress, as hopefully borne out in the numbers, and we will continue to use every opportunity within our responsibilities and powers as an integrated care board to make sure we stimulate more NHS activity in Brighton and Hove. But that's our perspective as an ICB chair. Obviously, we'll leave to you whether you want to draw in our dental colleagues who will give their own impressions of both national contract reform and how well NHS Sussex has been doing.
Thank you, Gary, and thank you, Ellie, for that presentation. I will now open up the floor to members if you have any questions, and remind you, as Gary's just said, that we do have practicing dentists on call. You may wish to ask questions of them, should you be minded. Do I have any indications? Councillor Simon.
Thank you, Chair. I've got two types of questions. One about the sort of some of the technical aspects, and then some kind of other questions about provision. So, in the technical aspects, in terms of the idea of contracted activity levels, are the expectations consistent across all of the practices? You mentioned that some practices have more than one contract. I don't really understand why that might be. If you could explain what the practical implications of that are. And you have said that, and I understand that we don't measure this contracted activity based on the lists of patients that dentists might have, but they do have them. They do have lists of NHS patients. Is there any monitoring of how many lists, how many people that they have got on a list at any one time that are, that are accessing NHS treatment? Is that part of any monitoring? And then, and the other one is how dentists is there any consistency required regarding how different practices communicate when they're able to take on new NHS patients, because that seems to be a bit pot luck in my experience. So those are my kind of like technical explanations, and I've got a couple of others if that's okay, but I'll leave that. There's enough of them to start with.
Hopefully I scribbled that down. My shorthand is not very good. So I will do my best, Councillor, and obviously I may turn to Ellie and to our dental colleagues as well. So just in terms of expectations of contracted activity, I think that was why we wanted to put a little bit, and apologies if it's still a bit arcane, we recognise that explaining to any normal person how these contracts work is extremely complicated. It is quite a specialist field even within the ICB. Not many people understand how dentistry is commissioned. So I suppose in terms of expectations of contracted activity, we work on the basis of historical contract values. So it is very unusual. So we have a certain amount of units of dental activity that we are funded for as NHS Sussex, and that is a received figure that we took over from NHS England when they were previously responsible a few years ago, and goodness knows when before NHS England existed the figure came from. So there's always been a budget allocation, and that pays for a certain number of units of dental activity. So that's why you'll note in the paper that we're constantly trading, if you like. So if we decommission or if someone is underperforming and we terminate their contract, we then seek another provider to re-provide that exact number of units of dental activity. So we're constantly trading to try to get the full number that we're funded for delivered. So when you see references to we're at 86% or 88%, that's 88% of the total number of units of dental activity that should be delivered, that we are funded to as a NHS body. So very happy to try again, but it is very complicated. In terms of more than one contract, and again, apologies if that's slightly muddied things, I think what I mean is, so for example, Smile Dental is a relatively well-known corporate brand, a bit like Boots. In the same way that Boots say, when we say you have X number of community pharmacies in the city, that may involve several of them that are Boots. I think I'm simply making the point that when we say it's 43, it's not 43 it's 43 contracts, but those contracts, several of them could be held by the same body. So it could be Smile Dental as just a typical example. So that's all I meant by that. In terms of list monitoring, so the ICB does not monitor individual practices and how they run their access models. We do have a role in various aspects that touch on it, though. So I mentioned that each individual provider that is signed up to an NHS dental contract, we are constantly monitoring how many units of dental activity they're delivering against how much we've asked them to deliver. So we've put in there that there are 2 terminations. So there are 2 providers in Brighton who we have terminated because after reasonable attempts to try to get them to deliver, they have not delivered. And so we have terminated their contract, but that has ended, and we have sought other providers to deliver the activity. So in that sense, we're very involved in how they're delivering. We are involved in complaints. So part of the ICB statutory role is we do have a function, so we will become aware if there are complaints raised against an individual provider, and we do respond to those. We would obviously respond to any councillor request we got, and we also respond to obviously local members of Parliament. So that's a more of a sort of soft element, but we are involved in that. I mean, ultimately, patients do have the right to make a complaint or challenge whether they are clear. So some of the things we sometimes get are whether patients are clear, whether they're being seen on the NHS or whether it's private, particularly where a provider has, probably with good intentions, tried to lower their private non-NHS costs to kind of match NHS fees, but that has confused things quite badly at the beginning of the pathway, which links to your final point, I guess, which is yes, with 43 separate contracts being delivered just in Brighton and Hove, there will be variability, but we work with Health Watch, and we are fully open to any examples people have got about confusing communications. In terms of the NHS website, I don't know, Nish, if you wanted to come in, but obviously that's something we hear quite often from patients saying, I've been on the NHS website, it says that this provider is only open to children or not open to anybody. We've mentioned some of the things we're doing to get more activity, and we have our NHS Sussex Dental Helpline, but I don't know if you wanted to say more from a dental chair perspective around that, because you must hear that quite a lot as well.
Thank you, Gary. That's absolutely right. Chair, can I also have your permission just to give you a bit more background? I'll come back to the website in a second. And that might answer some of the questions that have been asked. Firstly, I must say the LDC has been absolutely proud and honoured to be working with the ICBs. They have done most of the initiatives by consulting us. So we've given them an idea whether we work in practice or not. And I must say they've done a lot better than the commissioners we had before. Most of the incentives that we've talked about, my practice is undertaken at the moment. The 0 to 3 children has worked out really well. We've got families coming in, we're teaching to families about prevention. I think the one thing we've got to remember is prevention, prevention, prevention. However, we've done the Golden Hello as well. We've got a dentist from abroad to come and work for us. There was no dentist coming to an area to work for us. So all these incentives are helping. But the final thing I've got to say to everyone is there's no new money for dentistry. Basically, the contract payment stays the same for the same number of UDAs. The new reform contract Gary mentioned earlier will come in April 2026, but this has not been trialled. There will be an 8% of our contract to see urgent care. Now, my question always has been, if you're coming for urgent care, I can get you a pain, but what happens afterwards? You need routine treatment. My practice has not got the capacity to take them for routine treatment. I can take you for urgent care, then say, sorry, off you go, I can't do any more for you. The complex pathways they're talking about that will come in a new contract, that will have to be done over several months. Not many patients will return for this. We can see that happening already. The reform contract has basically increased the number of UDAs for certain treatments, like root treatment, for example. Now, what happens with that really is most of the practice will hit their targets. So as soon as they hit their targets, they can't get any more UDAs. So to increase access, there has to be more money come into the area. Most practices are struggling at the moment because of increasing NI contributions, increasing minimum wage, increasing sundry costs. Now, the websites, all practitioners are supposed to update their websites every 3 to 6 months, which we are doing. So if my practice says we're accepting patients, we will take patients on when we have spaces available. So we can't take everyone in one go. We take people on as we get spaces coming in. So we get them dentally fit, then we put them on recall, 6 to 12 months, maybe, or 18 months. That creates a space. So we bring someone else in. So I hope that explains or gives you some background as well. And Ali, if you want to add on something to that, you can as well. Or Aisha, if you want to add to that, you can.
Thank you, everyone. No, I think I side by Nisha's thoughts and views. I think it's perfectly great. It's just how we budget running a practice as a business. And as Nish said, we haven't had any increase to our contract or funding from NHS. So unfortunately, that is the scenario. So if we are going to accept new patients, we will need some sort of funding. Now, if we're going to keep churning out the same contract value or the contract within the contract, we're just churning out, as Nish said, if you're going to finish our UDAs quickly, then the problem will be access. And again, if patients are unable to access, then we're going to go back to square one. So I do agree with Nish and Nish's point. I hope I've made it really simple and clear. So thank you.
Thank you, gentlemen. An indication from Jeffrey.
Thank you very much, Gary, for coming in. I have to say that for Healthwatch, this is one of the most received calls about access. We did a survey in 2023, and we followed up with another one last year, and there's been marginal increases in access, but it's still not a good story. It's like turning around a giant tanker. And I'm afraid we do get lost in a morass of statistics and contracts and units of care and all the other stuff. People are judging access by their own experience, and the majority of people still cannot get access, like it or not. So the horror stories of people extracting their own teeth will prompt action up in Whitehall from time to time. But it's episodic, and as the last contribution pointed out, without real money, and the golden hellos are not working, and the fact that we've got to attract dentists from overseas tells me that further down the line, places like the Eastern Dental Clinic are not getting people in to train as dentists, and if they do train, they're not going to be in the NHS because they'll go into a practice that maximizes profits at all else. And the last survey we showed, it's still people will get a resort to paying for services rather than going to the NHS, which might provide relief for the NHS dentists. But, in a cost of living crisis, it's only the richest that can actually access dental health. Great stuff about champions. There was a very good program on Radio 4's Inside Health this week, I think. If people want to go to BBC Sounds, you can hear a wider picture of what's happening around the country with dentistry. But it's the contract is the issue. And if you don't pay enough and cover all the additional overheads that dentists have to contend with, including real living wage and all the other issues that come from the budget, you're not going to win. And the tanker will never quite turn around, and people will suffer as a result. So it's not a great picture. We will continue to work with you and try and advocate, health champions going into schools, helping primary school kids to learn how to brush their teeth and so on. But without more preventative care, we're just going to have a continuous demand, and it must be demoralising to work in the service and be on the receiving end of people who can't access basic NHS dentistry. And I think there's a problem, really, because all other branded services with NHS in front of it is free at the point of delivery. So if you say NHS dentistry, they expect it to be available and free at the point of knocking on the door, but it's not. So there's no question there's a commentary, really, I'm sorry, we'll all be slashing our throats here, but the reality of a bigger Sussex-wide survey just suggests that it's very marginal changes in people's experience of access at the moment.
There was no question, Gary, but if you want to comment, you're welcome to.
I think, well, just to say, obviously, there's a reason it's a strategic priority for NHS Sussex, but, and I'm not going to talk too much about the national thing, but it's no accident that the government has a manifesto commitment and there are national targets and there's been national contract reform. One thing I would say is the national contract reform is billed as that's the first bit of it. So underwhelming as it may be to some, and I can see Nish's hand has gone straight up as you were talking there, but so he'll give his own perspective. I think it's been described as the biggest tweak in history by one particularly tongue-in-cheek commentator. But it is meant to be a programme of contract reform, so that doesn't fix things. And actually, it does have some parallels, dare I say it, with the general practice side of what we sometimes come and talk to you about as well, which is, there's something about the ICB has a statutory role to work and enforce contractual compliance. It has a budget. It needs to make sure that's spent wisely for population health benefit using local intelligence. But also, there are limitations to how much genuine additional funding is going into some of these areas. So we work with the budget we have. So that's our commitment to you today. I don't know where we fit in the oil tanker analogy. I don't know if we're like a boat that's going alongside the oil tanker's sort of NHS England, but I probably should defer to Nish as an actual dentist.
Thank you, Gary. Nish, you're welcome to come in and comment.
Thank you. The analogy we're using, I think you probably want to say moving deck chairs on the Titanic, really. But Councillor, you're absolutely right about, look, I personally would like to provide national treatment to every patient that is available. Who wants to come to my practice, I would love to do that. But if you pay me accordingly, I will definitely do that. At the moment, my practice, being national health, we've also got a private element. The private element supports the national health practice. It supports a lot. If it went into the private element, I wouldn't be supported. Now, I think one way forward, and I think we need to talk about prevention. We're not doing enough prevention. If you paid my practice more money to do prevention instead of treating disease, we could try and prevent to get to a situation where we get to now. I think the new reform contract has not been trialed. We will not know what's going to happen. This always happens. They bring a new stuff in, don't trial it, and then we're into trouble. You're asking dentists to do more work for less money. I agree with the councillor. You're right, absolutely. You can't do that. So it's basically a Titanic, really. It's sinking. Thank you.
Jeffrey, do you want to come back very quickly?
I'll just come back quickly. No longer a councillor, a recovering politician. But in the words of Bob Geldof, if you're listening up in Whitehall, show us the money, because without the money, we will be having this same conversation next year and the year after and the year after that, because without real funds to pay for the technology, the employment costs, the rent and all the rest of it, we will still have access issues forever.
Councillor Goldsmith.
Thanks, Chair. I think I understand that the contracts are very complicated, you say, in the way that it's done, but in terms of trying to get an idea of like real people in this picture, it talks a lot about the units of dental activity and per head. What is the average per like actual user, NHS user of dentistry? Like, what is their average unit of dental activity for them? And then I just also wanted to ask sort of a little bit about the 3 to 5 year olds and just maybe some specifics on how that's being implemented in Brighton Hove and whereabouts we're having that. And I think just finally, the golden hellos, the fact that didn't succeed last time around. sort of any insight as to why it didn't succeed and what we're going to be doing differently this time to try and, even though we've doubled the numbers, like, yeah, why we think it might be successful this time around when it wasn't before.
I think I'm happy to turn to Ellie may have some comments on this. I mean, what I would say is a unit of dental activity, yes, it's a very dry measure. I mean, patients would have multiple units of dental activity over a course of treatment. So I guess it depends what they've come in for. So the simplest would be, I've come in, you pulled my tooth out, I mean, I'm being dramatic, you know, and that's it, which is not the recommended pathway that we want to have in place. But, you know, a normal course of treatment takes a couple of visits. And of course, then you're into that complex thing about the national contract reform. It was trying to work out a patient might need multiple visits. That in particular was not very attractive to a dental provider when they were looking at how to structure their access and their appointment book, because obviously there's a lot of intervention needed to try to stabilise the patient's health. But I don't know, perhaps I'll turn to Ellie in just a second if that's okay. Ellie, if you could cover the 2 to 5 year olds, apologies counsellor, that you were asking about.
The toothbrush.
Yeah, so Ellie will be able to say a bit more about the toothbrushing and the baby toothbrushes and the pots and stuff. In terms of golden hellos, I don't have the detail in front of me as to why. In some ways, Brighton and Hove is probably a victim of its success because, as you know, it's one of the more interesting places to live in the country. You know, it has an awful lot going for it, but it'd probably be quite similar to some of your other key worker things about, you know, do our providers in dentistry in Brighton and Hove have the best estates? We've got 2 local dentists on the screen. They hopefully have got very nice estates, but Brighton and Hove has obviously got a lot of period architecture and stuff. There's probably a few more providers that are in buildings with leaky roofs. It's been raining for weeks. There may be something about cost of living. There may be something about some of those quality of life aspects. But I don't know, Ellie, if you wanted to chip in on those 3.
Yeah, I think it's with the golden hellos, it's one of those where it's just so variable. Like you need to attract someone into the area. So when it depends where you're looking at really, and you kind of just have to try again. And you have what's called dental deserts where you just don't get people who come and practice. And when you're asking them to work in NHS dentistry, they obviously don't get paid as much as they do in private practice. So then coming to live in Brighton, which is one of the more expensive places to live in the country, it can just be harder to attract people to come down. But that's why we've gone out and offered more, and hopefully we'll be successful this time. But there's a timing thing with all of these things. Like maybe this time around there'll be more dentists who've recently graduated and want to live somewhere a bit more fun and exciting. We'll be more lucky this time around. But it's one of those you should try again in terms of recruitment. In the paper there's 2 things for children. So there's our pilot that we're starting, which is the 0 to 3 year olds. So we get them in, they will get a toothbrush and a toothpaste, and then our oral health champions, when they go to visit nurseries, they also give out the toothbrushes and toothpaste there as well. But there's also the supervised toothbrushing scheme that is, which I'm assuming is what you're touching on, yeah. So that is being run by Sussex Community Foundation Trust, and I double checked the numbers before I came, but currently in Brighton and Hove, I think they've seen 37 nurseries now have been trained to deliver that, and I think it's 7 schools, which equates to about 1,400 children who are getting that daily when they're in school and in nursery in Brighton and Hove. I don't know exactly where they are, I can ask, but they're starting in the more deprived areas first, so you could probably assume North West Brighton, that sort of area.
Nish, I notice your hand is up. Is that a historic hand, or are you wanted to come in on
No,
that?
this is that. I was going to come in with the golden hellos. Myself, Ali, and Ashia, we are foundation trainers. We train dentists who come out of practices for 1 year in our practices. These young dentists who are qualified come in with a debt of £50,000. They see us work on the national health. They'll work with the national 1 year with us. At the end of it, we've done a survey recently. Majority of them do not want to work on the national health. They want to do private work. I think we need to incentivize them and say, guys, please stay on national health. It's worth staying there, and we'll pay you accordingly. But at the moment, the contract stays, this amount of money you're going to get paid. So if they go to the bank manager and ask him for a loan, they'll say, hang on, what's your 5-year plan? Well, there isn't. Every year we'll get 3% pay rise, and that's it. So the golden hellos don't work. They're tied in for 3 years. They don't be tied in for 3 years. So they've got £50,000, £40,000 to pay. So basically, most of them are going to private dentistry. We train them on national health, and they're going to private. I think we need to think about different ways of keeping them in the national service, incentivize them, give them salaries or give them extra money to stay. But there isn't anything there. So that's my input.
Thank you, Nish. Mary.
Thank you, Chair. Mary Davies, Chair of the Older People's Council in Brighton and Hove. So I want to make a couple of points about dentistry as it applies to the older part of the population. We know that demand for dental services increases as the population grows and ages, and it's the older residents of Brighton and Hove, it's the part of the local population growing. Tell us that many have been delisted from their NHS dentist list and have subsequently had difficulty finding an NHS dentist. When they do, the treatment is usually with a newly qualified dentist, and then that can cease when that dentist moves on. There does seem to be a shift towards urgent rather than routine care in the NHS, and stabilisation is not always part of the offer. Poor oral hygiene in older people causes pain and can make it difficult to speak, eat and take medications. And poor oral health is also linked to conditions such as malnutrition, pneumonia and heart disease, and is therefore a very serious issue for older people. You've just been explaining about targeted support for early years, and I wonder if there's any attempt to have targeted support for older people.
That's really helpful. Absolutely. I guess what I would say at the moment is that concept of not being registered, I think particularly lands quite, it's more difficult for the older population who I think remember similar to some of our general practice conversations. There's a different relationship with their local health practitioner where they had a continuous relationship. And there's no doubt there's no doubt that it is a bit more about value activity in some ways. So one of the reasons the National Dental Contract Reform has talked about complex packages of care, and some of that would absolutely be disproportionately relevant to some of the older population, is to try to incentivise a series of appointments of course of treatment. Which can kind of recall at the so I guess that's one thing. It's only a thing. It doesn't fix everything. I've said that the National Contract Reform is meant to be a process, and there's meant to be further negotiations and consultations to do more. I'm sure that all of the bodies, Age UK and Democratic, the older population will continue to make representations as part of that process. So they're on the next phase of consultation is. At least my microphone is going in and out. We have done a pilot in West Sussex where we have worked particularly around care homes, and we have particularly done some interesting, and again I might turn to Ellie in a moment. We are still exploring what else. I mentioned we will use every lever in our toolbox. That's not mixing metaphors there, but what I would say at the moment is we will continue to use every opportunity. So if there are any ideas that we haven't thought of, and a lot of what we do is talking to the dental profession to see what ideas they have, because of course they actually see the older population and they will know what their dental health needs are. But we're absolutely committed to improving access for every part of the population. We particularly mentioned the early years today just because that's often of interest, but it's not at all the only thing that we're working on. I think at the moment we're evaluating our care home pilot, aren't we, Ellie, to just inform for that particular population what we might do next.
Yeah, if I just add to that quickly. So yeah, the whole of last year we ran a pilot that aimed at, so it's a bit difficult. So before the national contract came in, there used to be a mechanism where dentists could go out and see frail and elderly patients. So once they reached an age, but they needed to see a dentist regularly, they couldn't get into the practice easily anymore. That doesn't happen anymore. Like, it's not actually possible within the contract. They have to have a special domiciliary care contract. So we did look at that last year because it was something that was raised quite heavily, especially in care homes, about people in care homes who were immobile and not able to access dentistry. So we did do a pilot last year where we actually trained a local, just normal dental provider to be able to go in to a care home and provide screening and treatment. it needed some tweaks. I'll put it that way, and we're evaluating it at the moment. But it is definitely something that we are looking at, and we've even considered potentially doing like an oral health champion model with care homes as well, because that might work. Because a lot of, and I'm sure the clinical people on the team on the screen will say the same thing. A lot of the time for elderly people, prevention is just as important as treatment, and even when you talk about people with dementia, etc., it's not actually worth pulling out teeth, etc., unless people are in pain. But as you said, they need to be able to eat, they need to be able to speak, they need to be able to, all of those things. And a lot of that is kind of prevention based. So we are exploring it. It's just quite a complex piece of work that is still being explored.
Councillor Galvin.
Thank you, Chair. Thank you for your time coming in as well. My question is about golden handshake again. And where you mentioned there are 43 contracts available, and several of them will be held by multi-practices like Boots or Smile Dentistry. Does that mean that any of these contracts wouldn't be available to encourage new dentists to come to this area? Thank you.
Short answer is yes, and in fact, it's not just the 43 contracts that we run in Brighton and Hove. We've also made that Golden Hove scheme available to what we call our special care and paediatric services as well. So we're just as interested in attracting dentists to fully staff up some of those services who look after patients with learning disabilities and some of the other vulnerabilities we mentioned earlier. We'd rather have 4 dentists into Brighton and Hove, which is our current target, agnostic as to which of the vital posts that they fill. And obviously, if we get more national schemes around Golden Hellos, we will continue to deploy as much as we can into Brighton and Hove.
Councillor Evans.
Thank you, Chair. Thanks for the report. I've got a couple of questions, actually. One is, all these extra nationally urgent care appointments or units of dental activity, I'm just wondering obviously I don't expect you to go into the detail of what the contracts say, but I'm quite curious as to how that is defined in the contract, like what is defined as urgent and how that's provided, because a lot of the complaints that we hear, and I have experienced this personally as well, is people who have an urgent problem complaining that there's a kind of gatekeeping system in place with receptionists deciding whether you need urgent care or not, and it being really difficult to get through on the phone even to your dentist or to, any dentist, that they've all got these interminable hold systems where no one ever picks up the phone unless they're calling you to tell you your 6-month checkup is due. But if you're calling them to say, I've got an urgent problem, it can take weeks of trying before you can even get through, only to be told by an unqualified receptionist that you're not urgent and that they can give you an appointment in 4 months' time. And that's a real problem, I think. So I'm just wondering what it says in the contract about what counts as urgent or not. Like, does someone telling you that they actually are in pain and can't eat count as urgent? Because it should, but I know that it doesn't necessarily. And then my other question is completely different, and you probably don't know the answer to it, but I'll give it a go. I'm wondering, following on from what Mary said, whether the NHS more widely has any statistics about how much money is spent on preventable heart disease, vascular disease, etc., caused by gum disease or poor oral hygiene, because the links are extremely strong and extremely well established and extremely well researched. And I just wondered, whether there's any data on that, like how much money could actually be saved by doing more preventive work in NHS dentistry by the NHS more widely. Thank you.
If I may, I'll answer the first one, and then I may cheekily pass to my public health colleague to answer about the second one about population health data. So, just in terms of what do contracts say, so Clinicians decide, it's very similar to GP this, isn't it? Clinicians, there's a clinical part of taking the relevant information and deciding what is clinically urgent. You might note that Ellie mentioned the concept of unscheduled care. So you've got urgent versus unscheduled versus routine. In terms of contracts, there is a very specific process, for example, for claiming for urgent dental activity. There is an FP17 form that should set out a basic level of information around what the treatment has been provided for. So there is an ability for us to, should we have the capacity and the inclination, do an audit of, for example, FP17 forms to see what has come through. In some of the other areas, maybe another example would be around oral surgery. So there are clinical thresholds around what a high street dentist, a mandatory dental service provider, should do, and then what you would regard as slightly more specialist, minor oral surgery. And again, we do, I wouldn't say police it, but part of our statutory role is to ensure that money is spent appropriately. So if we have contracted a provider to do one thing and a different provider to do another thing, we need to make sure people are being seen in the appropriate service, and people are, clinicians are working within their competence, for example. So I guess I'm sure dental colleagues will chip in about, so for example, Nish, Ali and Aisha will be literally working out who is urgent. So the issue about gatekeeping receptionists, I will probably defer to dental colleagues to say whether your receptionists are gatekeeping. And our NHS Sussex Dental Helpline, hopefully, so that's why we're doing the posters and stuff, is one of the ways to say you should not be waiting weeks on end to try to get through or anything. So that dental helpline can directly book people in to local dental practices. So anything we can do to continue to popularise that. If anyone has any examples of actual dental providers, of course, part of our role is we're very happy to look into that if patients are completely unable to get through. But I don't know if my public health colleague wants to venture about preventable disease caused by gum disease.
Yeah, really happy to take that, Councillor, and it's an area of interest of mine. So I'm Nikki Lang, I'm the new Director of Public Health in Brighton and Hove City Council. I did work on this. In 2018 to 19, I did a health economic analysis of the value of prevention. The savings are huge. So with any preventative work, you are saving times 4 or 5 in. One doesn't even have to go to heart disease, rheumatic heart disease. One can just go to root canals and surgical procedures, and the difference is huge. So if you look at what Ellie and Gary were talking about with pediatric admissions for tooth extractions, if you even go to adults and look at root canals, they are extremely expensive procedures, they're under general anesthetic, and they're highly specialized, whereas something as cheap and beautiful as supervised brushing, getting kids into that habit, water-only schools, staying away from sugary substances, the savings are immeasurable. The best part of the country that does this is Glasgow and Scotland with their Healthy Smile strategy. I'd be delighted to share that with you. And unfortunately, the health economic analysis that I did is not public. It was done for North West London Integrated Care Board, but I could talk about it forever. The savings are massive, and tooth decay is a marker of poverty. So there's nothing complicated about it. Thank you very much.
Councillor Evans, you want to come back?
Yeah, I just wanted to say, I guess what I'm asking is there a conversation in the NHS about, the sensibility of refusing to give more money to dentistry when it could save them so much money if they did, given that analysis exists?
I guess what I would say is that is a ongoing discussion amongst all 4 parts of primary care, GPs, dentists, pharmacies and opticians, who all see the vast majority of all NHS activity but get a certain percentage of total NHS resource. So without being their spokesperson, yes, that's an ongoing debate. As I say, our role is to maximise what opportunities we're given. So any funding that's made available to Sussex, we will always try to invest it using that population health data and knowledge. So, for example, our new neighbourhood health team approach that we're trying to do in Brighton and Hove, this will be one of those areas. You know, some of the things we've mentioned might be delivered by bringing together high street dentists, specialist dentists, and the hospital.
Thank you. I have Nish indicated he wants to come in, and I also have Nora, who's been waiting patiently online. So Nish, if I could ask you to make your comments brief, and then I can bring Nora in, and then Councillor Parrott.
Thank you for talking about prevention. I'm so happy you talk about prevention. Prevention is the biggest thing we would like to do. Now, as dentists, we've all been asked the National Health, can we do blood pressure checks in our practices? We can then diagnose hypertensive patients. Why can't we do smoking cessation? That would be preventive. Why can't we do blood glucose for diabetes? So we can all do this. We've got a good footfall in our practices, but yet we do not get paid for any kind of prevention work at all. I think we can prevent disease, we don't have to treat disease. And I think that's important. And coming on finally to the councillors in a question about the blocks in the practices. Well, my practice receptionist always takes a pain history, and that we pass to the dentist, and the dentist decides what is urgent and what isn't urgent. Please remember, we have to treat our routine patients in the meantime. So these urgent patients are being squeezed in. They haven't got slots that we can squeeze them in. We try and bring them in. So our practices, most practices, as far as I know, do take a pain history and the dentist decides. But I think that's what we're talking about. So I'll be very quick now. Thank you very much. I'm done.
Thank you very much. Nora.
Thank you. Yeah, Nora, and I represent the community and voluntary sector. Really interesting. Thanks for the report. Although there are a few things, and I think it's been mentioned by others. One of the things that we know is really important is the preventative care, and we know that there's been some work with like the youngsters, like 0 to 3. I don't know. I haven't heard anything about hubs. Promotion of good oral health. You mentioned just now about neighborhood teams working more closely in neighborhoods, which is really great. Dentistry is still really challenging. There's a lot of barriers, and focusing on the younger generation obviously is really important. But we mustn't forget the older, the parents as well, and those that are working, and those, because it is really important that we are all able to have access to dentistry. We go to the dentist, we into account that some people, especially in more deprived areas, struggle to go to dentists anyway for reasons, including mental health. So I don't know what I'm trying to say here, but perhaps is there something around working with family hubs? I know in Whitehawk, for instance, there used to be a Coliseum Dental. That's not there anymore. So there's only one dentist there. And I think at the moment they're taking on NHS patients, but so many, if you go on the NHS website, there's just hardly any. And that's really, and if you can't afford to go and asking people and looking at videos on around oral health, I mean, I'm just worried that the issue we have now, we just continue to talk about it, and this has been going on for years. And the preventative care, everyone was saying preventative care is really important, but there's still not enough, funding in it, and I just don't really understand it. I'm going on a bit, but so anyways, I'm stop waffling now. But what I'm trying to say is there a clear dental pathway, commission all the stuff that you mentioned, using family hubs as well, in promoting and reaching out to families, not just the children, but the adults as well?
Thank you, Nora.
Sorry, I hope I'm clear. I know I said a lot. Thank you.
Luckily, there's a transcript, so I think you were breaking up a little bit. So I'm sorry, Nora, but I think I caught some of it. Well, hopefully it was correctly transcribed. So, I can see my colleagues just in the corner of my eye who are about to present on health inequality. So, if that was part of what you were saying at the start, you mentioned Whitehawk, which of course is a really important area in terms of wider joint working with the local authority around making sure that communities that need different and additional services have those. So our dental program is absolutely, we mentioned earlier about it being a very striking proxy around poverty, around oral health and the state of disease that some patients have through a lack of preventative care that's gone on for a long period of time. We've given some examples around, so we do commission very specialist services, for example, around special care and paediatrics. Special care can be some of the things Ellie outlined earlier about particularly vulnerable patients. They're not just younger patients. We mentioned care homes, for example, so patients who've got frailty and vulnerabilities, patients with dementia. There are lots of different types of inequality. Obviously, and I think the reference to neighbourhood, integrated neighbourhood health teams is very much because that is one of the new ways that the NHS more generally is hoping to work in a much more localised way to try to design services that are integrated and based around local population health need, for example, in an area like Whitehall. We did mention family hubs. I think I caught that at some point, Nora. So family hubs we mentioned, we're already explicitly working with, as Ellie said, as part of our 0 to 3 programme. That work will be ongoing. I mean, it's one of the reasons we work very closely with the public health team at Brighton and Hove City Council, and obviously they have good connections into the education department and the other parts of what the council does. So joint working, I think, is really important to make sure that we're taking advantage of other services. The poster we put into our paper, we've tried to send out far and wide. I don't know how many libraries and bus stops and what have you it's got on in Brighton and Hove, but I think that is something we need to continue to work on. I know Jeffrey described it as I think we ended up with the Titanic sinking by the end of that particular discussion. It wasn't, but the deck chairs on the sinking Titanic. But either way, where we do have services such as they are, and we are trying to improve it within the limitations that we have, we do need to try to promote that so that people are aware. Because patients certainly shouldn't be spending weeks and weeks trying to get an appointment. But apologies if I've missed some of what you said, Nora. I'm happy to do anything afterwards.
Thank you, Gary. Councillor Parrott.
Thank you for your presentation. Really, it's following on from Nora's comments about use of hubs and connectivity back into community. Obviously, we know that poor dental health is, closely intersected with all of the variables that make up inequality, not just poverty, but obviously we've got huge issues around disability. And I was just thinking, for example, with a couple of young people I know who have multiple complex needs, the cost of treating them when they have dental health must be enormous because, getting them there, treating them is huge compared to something else. So prevention in those areas, of course, is very key. So there's a real link there. But one of the things I was then wondering was, are we taking that step backwards around co-production and actually really working with our partners in the community sector? We've got the Older People's Council here. We've got Nora. I'm thinking of people like Speak Out. I'm thinking of, various community partners that we work with as a council, where actually if we were working with them right up front, we could start to identify how and where we meet with those communities that are possibly causing us the most, are costing us the most in terms of ongoing treatment. So that was one question, was around co-production. The other question I had was, you mentioned, and I would agree with you, that, the infrastructure in the city is probably quite poor around some of the dentist practices, not their fault, but, we've got ageing centres, etc. Is work being done to look at dentistry hubs and making sure that we've got new infrastructure that will meet the needs? We've got brand new hospitals going up, we've got a big cancer treatment, centre, we've got all sorts of exciting things happening. And so I'm just wondering, is there work being done to provision and to look at asking for money for, obviously, infrastructure, which will enable us to move forward as well, because we've got this issue now, but we also need to think about the future. We've got an ageing population, we've also got rising health inequalities, and we've got rising disability in the city. So we know that this isn't a problem that's going anywhere. So my question would be around, are we, new treatments are going to come along, new equipment, all of which probably is going to require better facilities to house it in, to put it in, so that we can make best use of it and have best practice around some of that. So I was just thinking, is work being done in that kind of, behind the scenes, which is more about how are we planning for the future, not dealing with the current crisis, which I know absorbs us all, but unless we also start thinking about how are we planning forward thinking, how we're going to manage. Sorry, I hope that's not too.
No, that's very helpful. Just in terms of, you're right. Inequality is a very broad term, but I don't want to steal the thunder of my more expert colleagues who are about to talk about it. But yes, things like disability, we didn't put everything in the paper we could have, and obviously disability itself is a very umbrella term, isn't it? So one of the national things at the moment is every integrated care board is being asked to procure additional services into residential settings, so eye tests, dental checkups, etc., for patients with special needs. So there will be a certain number of those within the Brighton and Hove City Council boundary area. So just as an example, access to us is all-encompassing. So another umbrella term, access. But for us, it's really important that we do work with. You mentioned co-production. Absolutely. Do we do enough co-production? No. Do we want to do more? Yes. Are we open to ideas permanently as an ICB? So I don't want to make any false promises, but of course we're very happy to. One of the reasons we talk to Healthwatch is not just to take the Titanic sinking survey type thing. It's also to try to use connections that people have, and obviously councillors have just disproportionately wide connections. And certainly if we're planning to do something in the city area boundary and we're exploring ideas, we should be reaching out, and we should be doing that local engagement. Last thing, I certainly don't want to give a false promise around infrastructure, because capital funding is extremely limited, but I can assure you that wherever that is being discussed in terms of the future of Brighton and Hove, so things like neighbourhood health hubs, you may have seen in some of the national policy documents, dentistry is going to be one of the considerations in that mix, but no promises yet. But yes, we need to make sure that we have services in modern, appropriate facilities, not just for the people delivering the care, but also for patients receiving it. So.
Thank you, Gary. Do I have any more indications? I do. Councillor Mackie, and Councillor Simon, and Councillor Winder.
Thank you. Just before I ask my more substantive question, picking up on the disabilities, you do say that you're hoping to have dental checks in SEND facilities. Is that a hope, or have you got an action plan for actually doing it? Now, my main question was in part 6 of your report. You talk about continuous improvement. So what support is given to the providers in Brighton and Hove who are experiencing challenges in order that they can continue to provide the NHS services? Can you describe that support, very briefly, but also would you be able to measure its effectiveness and report back possibly to us on that? Thank you. Thanks, Chair.
I will turn to my colleague Ellie in just a moment about the specific plans. Yes, it's not a hope. We are procuring. It's a full public procurement around what we're doing. But I'll turn to Ellie in just a moment, if I may, who's been leading on that for Sussex. In terms of continuous improvement, I guess what I'd say is the traditional relationship with dental providers has been extremely different to things like hospitals and GP practices, where CCGs, PCTs, and now ICBs, to quote our acronyms, have always had a role in funding things like quality improvement, or with general practices we fund something called practice resilience. If they've got real shortages, those 5 doctors all went off at the same time on maternity leave and they're really struggling to keep running. I think a lot of that is completely countercultural with dental providers. I will defer to dental providers to see whether they agree with me. But, given that they are mixed models where they do an element of private activity, they have a certain number of units of NHS activity, they make their own decisions on things like buildings and premises. We don't have the same responsibilities with those providers as we do with GPs. So we are part of the rent reimbursement for GP practices. We don't get involved in any of that kind of stuff with dental providers. So I think it comes from that different starting point, if that makes sense, that we've never had that relationship. That was what we inherited when we took on delegated commissioning. One of the reasons it was delegated was to try to bring the commissioning body closer to the ground. And I hope today has given you an inkling that relationships are certainly, I think, quite positive and open. We have introduced a specific, for example, practice resilience fund for dentistry. Early days, I think quite a lot of dental providers have been a bit bemused, if I can put words in their mouth, as to the ICB wants to give me money because I'm making a loss. It's kind of some of the conversations we've had. So there's more to do, but ultimately that is because we want providers to carry on doing NHS dentistry. Things like premises, we don't have the same responsibility, but if there was an opportunity to support a dental provider who said they could do more NHS dental activity if this or that happened with their premises, I'm sure we'd be happy to talk. The last thing is the contract, national contract does include some specific stuff around quality improvement activities that it wants more of. And that's something that's also similar to community pharmacy, where there's always been a bit of an element to their contract as well, which is we're not just paying you to do stuff. We also want to pay you to have some time out to do some quality improvement work, to try to generally up your skills, keep on top of the latest best practice, and sort of translate that into what you actually do day to day with patients. But I am talking a little bit about what dentists might say. Do you want to quickly say what we're doing on the SEND schools?
Yeah, so for the SEND school, so I can't give specific dates because we only just started working on it, but it was for site tests and for dental checks, and it's in residential. So the site test is at residential and day schools for SEND children, and the dentistry is for only residential schools only. We have made progress, so the site test is out to tender currently, and we're just starting to work on the dental checks now. It is happening. We're doing market analysis with the schools in Sussex who have indicated that they'd be open to a service once it was up and running, and we are starting to talk to set up engagement events with providers who might be interested in providing the service. So it is happening. I can't give you an exact date as to when it will be done, but we are working on it.
Councillor Simon.
Thank you, Chair. Is there any information or data around the geographical areas or population groups where access remains particularly poor? And I'm interested in knowing how, if that is the case, that is measured, and if it isn't the case, how it could be measured, so that we can kind of monitor any changes or improvements for more vulnerable groups, but also more vulnerable geographical areas. I'm from Woodingdean. We have 2 dental practices there. Neither of them are taking on patients. It's quite a specific geographical area, and everybody who wants to get NHS care who isn't already there with them has to go somewhere else, which involves several bus trips, etc. So I'm interested in the sort of geography of how we measure that. So because we know what the I can't think what you call them, the activity levels are, but if we're not measuring the lists, which we're not, then how do we measure kind of per head of population how much activity is going on, or who might not be getting some help? Thank you.
I think they're really important questions. I think we're in the early days of having more granular information around that. So, as I say, my colleagues will be about to present on health inequalities. Some of the data that we have around dentistry is weaker historically than it is around things like hospital appointments or emergency admissions or things like that. So, in the paper, we've got a table which is quite complicated, so apologies if it's confusing, but there's something about aspirational levels of units of dental activity per head of population. That is partly based around looking at IMD scores and looking down at ward level. So there are different numbers for different local authorities across Sussex. So there's one for Brighton and Hove. It's potentially controversial, so we're going to West Sussex HASC next month to do a similar paper on dentistry. They may say that we've got it right or wrong. They've got 7 figures because they've got 7 lower tier authorities, there's one figure for Brighton. Because it's only one figure for Brighton, that will be masking, as you say, the complexity of the Brighton and Hove area. So when I mention putting a lot of faith in neighbourhood health teams, but part of that has been looking at population health data and trying to sort of pull together information to show local providers and populations what the outcomes are. So forgive me, I can't remember which one of the neighbourhood health teams covers Woodingdean, but that should be something that we're working on with public health colleagues around that oral health needs assessment. So what we can tell is how many historic contracted units of dental activity are provided, but that is not based on population health need. As I said, that is some slightly quirky retro figure that's come down to the ICB. We will be looking with interest at the national contract reform to see whether that gives an opportunity to maybe move away from some of that without in any way prejudicing what the profession will feedback about what they're interested in. But for us, it wouldn't be where we would start from. So if we had a completely clean slate, we would be looking at the total budget we have. We would be looking at a stronger set of population health data, and then we'd be saying, where would you put a dentist? But of course, that's not how it works, and it's the same for all the other services as well. So we're starting from a particular vantage point. What we're looking for is better data. I won't do it today, but we have been working very much with our clinical lead inside the ICB and public health colleagues around how we can do some targeted work around oral health needs assessment. How do we get a better map of what the local data is? We know about tooth extractions, we know about units of dental activity. We have bits of the jigsaw, but it's not a complete picture. But it will be a priority.
Thank you, Gary. Councillor Winder.
Thank you. I just wanted to ask about the level of in-depth data gathering and mapping you might need to do now to get those locations of dental practices and services mapped out in relation to the populations that need them. Because I've heard that some dentists find it very difficult to find suitable premises, and obviously there's a high cost to that in some areas of the city, but some areas desperately need dental services, and yet there aren't any located there. And is there a way of actually using that mapping process to get more provision targeted where it's most needed? And what are the kind of barriers to that? Thank you.
I mean, the short answer is yes. I mean, whatever data we have is, I mean, without going into the ICB changes, because I think that's also on the agenda at some point. But, you know, part of our transition as an ICB into being a strategic commissioner is absolutely that kind of line of thinking. So how can you strategically commission things like dentistry? Well, first of all, you need to know what your population health need is. You do need to know what your budget is. You then need to try to triangulate, I guess, with how well current services are working. I mean, we procured a full-blown new contract, which we're very grateful for in Hove, about a year or two ago now. I mean, that new provider was a competitive process. So why Hove? Why that particular building? Some of that is self-selection because the providers will need to either have a viable building or they will have had to do some research and stuff. So, you know, there will be some areas where the state of public infrastructure is such that actually they come from a weak starting point, that no provider they might want to do the NHS activity, but they won't want to do it there because actually there's no parking and there's one road in and out and it's always flooded, you know. So I think at the moment, more work needs to be done is the short answer. We've mentioned all the different procurements we're going out to. We currently don't have a plan to do a full-blown procurement of a brand new practice, but as soon as we get the opportunity to, just like we did in Hove, we'll do it again. And then we'll be back to, working collaboratively with partners like the local authority around, well, where do we most need it? But yeah, it's a work in progress is all I can say.
Thank you, Chair. Do I have any further indications from members? I don't. If you'll indulge me, Gary, I just have a couple of questions of my own as Chair. And I guess in doing so, I'm wrapping up a lot of the questions that have been asked of you already around the movement to urgent dental care over routine care, and also quite a few questions have been asked about equality to access of dentistry. So I just want to frame a couple of questions around that. and then I'll let you go upon your day. So my first one is the national dental contract, as we know, the reforms are due in April 2026. And I guess there has been some expression that urgent care is going to displace routine care because of that, and that's been expressed and shared by some of our dentists online. So I guess one question that comes out of that is what, if any, local impact assessments are being done to understand whether these reforms will improve or further challenge access for our vulnerable populations in Brighton and Hove? That's the first question. And in relation to that, and Councillor Simon has talked about it and others, that specific data that isn't really being collected that would be really helpful in monitoring, for example, the proportion of patients we have in deprived areas or minoritized communities, or those with lower health literacy, for example. Are they registered with NHS? Do we know that data? Do we know what proportion of them are registered? So I guess my ask out of that would be if you're willing to come back at some point in the future and provide a more in-depth insight into that, because having that baseline is really useful for us to be able to go on to see if we're making improvements in terms of that access. And I know we're going to touch upon that in a further agenda item today on inequalities within the NHS. So I guess I'll leave it at that. There is a concern, I think, being felt today that urgent care is going to push out routine care, and it is clearly going to have impact on some of our marginalised and vulnerable communities. We just need to ensure that we keep the optics on that, get some baselines monitored, and then programmes that come into place, are they being successful, or do we need to tweak them in the future? Thank you.
We haven't set up my colleagues to, I'm sure they'll do an amazing presentation. So I'm sorry I keep talking about inequalities before you get the chance to. But so on the data side, I think I'm happy to take away that challenge. At the moment, there are sort of things like pharmaceutical needs assessments, for example, where there is a very structured process where public health lead and the Health and Wellbeing Board has a role, etc. It's just different with dentistry. So I think we're starting from where we're starting from. I think the concept of an oral health needs assessment is a good one. We have commissioned some work. It's only a small piece of work as an ICB, more generally about looking into that with our clinical lead, who is an extremely good dentist from Yorkshire. So he is, but he has been integral to everything we've done in Sussex over the last few years. His objective opinion has been fantastic. He's really been challenging what we can and can't do within the limitations of some of the national frameworks and stuff. So I think for now, probably happy to come back whenever you decide as a committee, but it would involve joint working with public health colleagues around, I guess, how can we develop a true picture of oral health need for Brighton and Hove? And I think that's very relevant to the development of the neighbourhood health teams, if I may say so. In terms of the general thing about urgent care displacing routine, that is a very big national talking point. So it is national policy. It's national commitment around urgent dental appointments. Hopefully we've given a sense today that previously and now we are trying to stimulate all types of NHS activity. So routine, unscheduled, urgent. Some of the national contract changes will drive I think Ali said it earlier, kind of burning through of units of dental activity to do certain types of activity. But there is also that thing about that complex treatment pathway, that new package. I don't want to give false hope, but, I have to be optimistic about some of these elements. Whether they in total add up to a fix for NHS dentistry is a much bigger question, as has been posed earlier. But for now, we will be monitoring the impact of not just the national, but our local commissioning schemes, where we see under delivery in what we've already contracted. We've already had evidence that we've terminated contracts in Brighton and Hove, and we will continue to make sure that people are delivering what they're contracted to deliver. If they can't, we will try to find people who can deliver it so the population has access. But we're very happy to come back, of course.
Thank you, Gary, and thank you very much for that offer. I've just noticed that Aisha has an indication online. Aisha, do you want to come in?
Yes, thank you so much. Basically, I mean, I do provide the urgent sessions in the practice, and a lot of time our sessions are wasted with there are no appointments booked in. The appointments are booked through the helpline, and quite recently, there are hours wasted. So I sometimes do struggle to understand when public complain about not being able to find an appointment, and then we are sitting in the clinics 3.5 hours with only one appointment booked in. So, as a clinician, it's a little bit difficult for me to understand that there is a lot of hoo-ha about not being able to find NHS dentists, and then in clinics we have our time wasted because of that. When we call helpline, they say, well, it's been very quiet today, and things like that. The other thing I wanted to ask here is that you are talking about contract procurement and things like that. I mean, I am not a political person. As a clinician, you have no idea how difficult it is to deal with that. I've looked at it when recently there was a sedation contract, and I actively wanted to participate in that because I personally believe NHS is a really good system, but we just maybe need some changes. But for general public, it's an amazing system that we have here for dentistry. And when I try to increase the services, it's not easy for clinicians to do that sort of thing. And I checked back and forth that if I can get any help, but I wasn't offered any help about that. So if in future there is an opportunity and I want to avail, there is no guidance for clinicians to do that.
Thank you very much, Aisha, for your comments. Nish, I notice an indication from yourself again.
Yes, sorry. Firstly, Chair, can I thank you very much for inviting me and my fellow colleagues to come to this committee meeting. And Gary, thank you for your presentation. From today, can I suggest to everyone to lobby your MPs for more dental funding? I think we need more dental funding to address these issues. Now, from a personal point of view, and it's a personal suggestion, please, the Treasury knows exactly how much money they're spending on dentistry. I think it'd be prudent for the government themselves to set up practices with salaried dentists, definitely for the vulnerable groups mentioned, children, OAP, special needs. I mean, they could have their own recruitment and retention schemes. Then I would suggest open up the market because competition is healthy. We will have to work hard to service it. But, you all mentioned these things about new practices, new environment, well, it all needs money to sustain this. We are businesses. We're small businesses trying to make it a living, but yet we have difficulties. I mean, I should understand what you just said, but I think Gary is trying to help people like dentists, general dentists, to apply for these fundings as well. So we'll get the LDC and the ICBs are working together to do that. So we will get there. But Chair, thank you very much for your time.
You're welcome, Nish. Thank you. Okay, folks, I'm going to bring this to a conclusion and ask our members happy to note the report. Thank you. At this point, I'm going to take a 5-minute comfort break for everybody. Appreciate we've digested a lot of information there. Gary and Ellie, thank you very much for coming today, for your presentation and for patiently answering all the members' questions. And I wish you well upon the rest of your day. Thank you. Thank you, everybody, and welcome back to the House Committee. Now moving on to item 25 on the agenda, reducing health inequalities in Brighton and Hove. This paper updates the committee on the extent of health inequalities in the city and the work being undertaken across the health and care system to reduce inequalities. It will be presented by Joanne Alner and Tanya Brown-Griffith from NHS Sussex and Dr. Nikki Lang, Director of Public Health. Following the presentation, members are welcome to ask questions. Thank you.
Thank you. So I think members of the council and the population of Brighton and Hove would want to see an improved population health and health inequalities at the heart of what was exposed through the COVID pandemic. And as a system, we've recognized that working together, working in a more integrated way, increases the dividends for the population. So what we're going to present is our integrated strategy around addressing inequalities in Brighton and Hove, particularly because Brighton and Hove, we know, experience pronounced and persistent health inequalities. There are significant areas of deprivation: Whitehall, Moulscombe, Hollingbury, Within Dean, to name a few. And also the city faces high unemployment, we've got homelessness, but also tied to mental health challenges, MSK challenges, acute housing insecurity, etc. So we do know as health and care and wider community working together in an integrated way will increase the reduction of those inequalities. So we're going to talk to you a little bit about the data. So Dr. Nikki Lang will refer to the data and the sets of information that we now know around the population health. And then Joe will talk to some of the integrated work we're doing in NHS Sussex, working with public health and wider stakeholders to look at our population's outcomes framework. And for the first time, we can map and track improvement or not in inequalities and be able to attribute that to service development. And as commissioners, what we want to do is to commission by population need, not a one-size-fits-all, and certainly tailor or resource and capacity to areas of greatest need. And I know Gary, my colleague, mentioned the neighbourhood health and the neighbourhood health teams and the government's left shift programme, and that is where we want to focus. That left shift is on addressing inequalities. So I'm going to hand over to Nikki, who will take you through some of the data sets just to set the context of the some of the areas that we want to focus on.
Great, thank you very much. Thank you for inviting me. If Giles goes ahead to slide, it's page 54, but it's the slide that says our population and building blocks of health. And then the next, sorry, change my glasses. Yes, that's right. So on this slide, we see the population of Brighton and Hove, and we can look, what may interest you, but we all know this, an increase in net international migration, but a reduction in internal, so that's within the same country, migration. That's changes since 2014. On the next slide, this is the important bit, and this is why it's important that public health is situated in a council. So wider determinants are responsible for 80% of people's health. So healthcare services, 20%, and then wider determinants like housing, education, skills, and employment have the biggest impact. And as Tanya said, lots of factors in Brighton and Hove that have a bearing on public health. On the next slide, this is a slide that councillors and also the voluntary sector and Health Watch will be incredibly familiar with. So the darker shaded areas are the areas of greater deprivation. Out of 153 English local authorities, we are ranked 92nd most deprived. And then we have a few statistics on the right about children living in income deprivation, and interesting councillors in the more deprived wards will recognise their area. On the next slide, We have housing and health. So housing, as we know, is an issue in the city with rough sleepers and also families in temporary accommodation. And there's obviously a huge interplay between housing pressures, and people's health and well-being. And on the next slide, we have education. So this is looking at skills, educational attainment, and just in that bottom right-hand corner, these are the wards in our city, which are in the highest rates of people in England with no qualifications. So again, members from those wards will know this already and be really familiar with it. On the next slide, we have data from health counts. So this may be data that you're all familiar with. So I know it looks a little bit small. There's changes in life expectancy for women. So that's between our richest and poorest areas across going from the years and widening, narrowing a little bit for men, but widening. And on the next slide, this is something that we know as well, that the bit to look at is the blob on the right-hand side, which shows least deprived to most deprived, but we can see that the mortality or the death rate is much higher in our inclusion health groups. And Tanya will talk about this as well. This is people who are homeless, people suffering with severe and enduring mental illness, and people otherwise marginalized in society. And we know this. This is something that Brighton Hove is acutely aware of. On the next slide, again, this is multiple long-term conditions, so this is plays into what members were asking about, and also Health Watch and Older People's Council. This is long-term conditions are higher in terms of prevalence in the more deprived areas. It's what we would expect, but again, that gives you that real potential for family hubs and integrated neighborhood teams. And on the next slide, these are the causes contributing to gaps in life expectancy. Again, we can skip over that one and you can peruse it. And we can skip over that one as well. These are just about behavioral risk factors. Health counts is something that Health Scrutiny Committee will be aware of. It's a large survey of about 17,000 people in Brighton and Hove that yields some really interesting results and actually gives us a bit more of a data picture of our borough, just because it's unique in some ways. And on the next slide, it showed a few inequalities. So we can see some widening inequalities and some health behaviors that we see. So in the left-hand column, you can look at the most deprived areas and see what people expressed about their health, well-being, and risk factors for poor health. And I think, just to go to the previous discussions, never visited the dentist. 16% of folks in the most deprived areas said that, but in our richest areas, only 6% said that. So that's an interesting one that relates to the previous presentation. And on the next slide, I think we'll skip this one. It's important. We'll get to the Safe and Well at School survey. This has been running for quite some time, I understand, in Brighton and Hove, and I met Professor Banerjee recently. This is something that we're hoping to build on. It's a really big school survey, so for members who have an interest in child health, this is really interesting. So if you look at low deprivation, just means richer, and then high deprivation, poorer. I know it doesn't sound very clear. But again, if you look at brushing teeth twice a day, eating fruit and vegetables, these are all things that have a bearing on the previous presentation. And then, next slide, please. I'm going to hand over to Joanne Ulmer for the next part.
Let's just tell you. Thank you. Sorry, Claire, you'll have to press it again.
Can you hear me? Yes. So I was doing the left, I should have done the right, the other way around. Good evening, actually, everybody. I'm Joanne Aulner. I'm the Director of Population Health and Inequalities for Sussex. and of course within that population is Brighton and Hove. My role really is to make sure that we, within the ICB, pay attention to the inequalities and then the health needs of our population. And one of the ways we do this is through making sure that we understand from the data and the reports that we receive, not only from our public health colleagues, but equally from people like Health Watch and our BCSEs and our insights from our local population in relation to how they're experiencing health and their outcomes generally across the life course. The population health outcomes framework above you there has been developed with all three public health teams across Sussex and ourselves in the ICB to really try and understand what are the metrics which we should measure over a period of time that can give us a sense of the directional travel of improving our life expectancy and our healthy life expectancy of our population. It's very specific to these two outcomes, partly because it's our ICB, it's one of our duties to make sure that we pay attention and try and address that through the actions that we deliver. And equally, I know as from a local council, it's very important for you in relation to wider determinants and the impacts of those. You'll see from the slide in your paper and also above there that it covers a life course, and it's really identifying the metrics which we think are quite high level, which will tell us if when we measure them, and these don't change overnight, these can take 6 months, a year to really see some changes. So they are sort of kind of like the North Star is what we're aiming for, but there'll be a number of metrics underneath these ones to enable the things we need to do to improve. So we've done well, last year we did our first assessment of what, and we called it the state of Sussex as into relation to these, and what that meant for our three different places as we call them in relation to Brighton, Hove, West Sussex and East Sussex, to see how we all performed in relation to the outcomes against these metrics. And you'll see within the paper a list of the areas where Brighton and Hove, East Sussex have got their own and West Sussex have got their own outliers in relation to areas of concern in relation to the endeavour of increasing life expectancy and healthy life expectancy. Now, as you've seen from the slides before, we have quite a reasonable life expectancy in the south and in Sussex. We know that people from who experience or have inequalities and inclusion health groups and deprived populations have lower life expectancy and healthy life expectancy, and you've seen in the slides before reasons for that and things that we can measure and understand. What's really important about healthy life expectancy for us all, not only from the population and their outcomes, but equally from a health and care spend and cost point of view, is the lower the healthy life expectancy gets, the more cost that requires, the more demand that is on our services. So not only is it really important for the individuals of our populations to live longer and live healthier for longer, it's equally important in relation to the services that we have to deliver as well. Now, in relation to healthy life expectancy across Sussex, East Sussex, Brighton and Hove and West Sussex women have all had a reduction of 3.3 years for East Sussex, just under that for Brighton and Hove, since 2011 to 2023. Now, this isn't unusual for the country, actually. It's been a similar picture in the country for women. Men have slightly reduced, but not the same level. Still, the healthy life expectancy is still less than women, but it has had quite an impact on women, and COVID is considered a considerable part, or the impact on that, as well as the cost of living crisis has had on that as well. Now, what that means to us as people have to deliver services and support our patients and residents in relation to the services we provide and commission, is that means we move in thousands of new people into a requirement for requiring help for their health and care earlier than they would have done 10 years ago, which then has a cost, and of course then they're in the system for much longer because our life expectancy is either stable or slightly improved. So we've got a bigger sort of age band really, of people experiencing ill health and but prolonged life expectancy due to the improvements in health and care and also medicines and the delivery that we give to them as well. So it's really important that we do focus on healthy life expectancy and life expectancy as a measure to think about that. Now, one of the things when I compare and look at West Sussex, East Sussex and Brighton and Hove, really that stands out in relation to Brighton and Hove is in relation to mortality, is around the external causes of of mortality, which aren't really shown in the other two places in Sussex. And external causes are really things like suicide rates, one of the highest in the country, hazardous alcohol intakes, one of the highest in the country, and also drug rates of death, etc., are high as well in Brighton Hove. So that's quite unusual in Sussex, if I looked at all three places, as to why people are dying earlier in relation to those three areas as part of that. So those are things I'd highlight to you. But in the pack, you'll see, and apologies, I'm not as clever on the slide 1, slide 2, you'll see a long list of different things, which of course have the responsibilities of health to address, like hypertension or blood pressure, health checks, make sure we've had improvements on that, making sure that we're looking at people's cholesterols and supporting them and treating them, and really doing early cancer screening and aspects of that, all the things that are important to us. And we recognise that's the important part we play in making sure we improve healthy life expectancy and life expectancy. Equally, a health inclusion group, which is really experiencing the high mortality rates, which may or may not be a surprise to you, is those people with serious mental illness. We already know that they die across the country and locally 15 to 20 years earlier than the general population. But we see in East Sussex, Brighton and Hove and West Sussex high proportions of people with excess mortality for SMI. So it's for Brighton and Hove, it's 442% higher than the general population in excess mortality. So basically that's saying if there was a person without serious mental illness and there was a person with serious mental illness, they were 442% more likely to die from that condition. So it's that they're a specific group which we want to pay more attention to, given we've really those figures have really spoken to us in the last year. So in the pack you'll see a lot of data and examples, and I'm happy to try and answer the questions in relation to that. But also in the pack you will see that there's evidence of us working collectively in an integrated way across the Brighton and Hove. Gary and Tanya have mentioned, and I'm sure you've heard before, us talk about integrated community teams. These are really important. These are our mechanisms now, really, of making sure that the community services, especially the health and social care and VCS services, really rally around their population as defined by the ICT footprint to make sure that they work together really closely to be able to support patients and residents within that population. Each one has a dashboard with their particular outcomes on there. Many of them are preventative and many of them are around the things I've just spoken about. And also they'll be working to improve that in relation to reaching out to patients to maybe make sure they have a blood pressure or it's monitored or treated if it's found to be higher than we would like. But equally integrated mental health services within those teams and aligning with family hubs. And also we have some ICTs which are specific for the multi-compound needs community of such as those that are served by Arch and the homeless. And I believe there's an ICT specifically for that population. You will also see in the pack an example of a day we had in December the 3rd around looking at some funding we have in relation to identifying in relation to funding some members of the BCSE community to make sure we have more insights into certain populations. We've recently done a review about the groups that maybe we've been missing in relation to the insight bank that we have and the evidence that we have. And we found that certain groups, we have less information, their voice is less in our conversations because of lack of the insight. I hope that makes sense. So, for example, people with physical disabilities and men, middle-aged men who we're not really hearing their voice as well. So we'd like to look more into that. But you'll see the themes that have come out of that day and what we were trying to address and actually something that's in play at the moment in relation to people expressing an interest in accessing £75,000 to be able to address that. But that's not the only thing that happens, and I know yourselves do a lot in doing driving and understanding insights into your local population, as does Health Watch and as does the VCSE, much closer to hearing that and bringing that in. I think I'll conclude there, but I would like to say that the Health Count survey that you do in Brighton Hove is an excellent piece of research, data collection. Through that survey, we are finding things out which we're not getting from the census, which is generally how we get most of our sort of population health need information. And I appreciate that you've done that. And I think the findings which are in this report as well are really helpful to us in driving and making sure we focus on the right things for your population, our population. I hope that's a helpful summary of the pack.
Thanks, Jo. So just to conclude the 4 questions, one of the next steps for us, and I just wanted to bring in at the end where the Health and Wellbeing Board provides a really important role in the city. And part of the next step is that we are refreshing the Health and Wellbeing Board strategy. And the highest content within that strategy is around addressing health inequalities. And our colleagues has referenced quite a lot of work around neighbourhoods, quite a lot of work around the multiple compound needs programme, which addresses homelessness, mental health, drug and alcohol, complex multiple long-term condition needs. And we know we have many people within the city who require specific services. So in refreshing the health and wellbeing strategy, there will be a higher content for the wider determinants. And as Nikki mentioned, they contribute between 75 to 85% towards health outcomes. So we want to ensure that we're tying health offer, mental health, physical health, children and young people's health to the reasons and the healthy activities, healthy behaviors, determinants of health, such as employment, school, homelessness, etc. Just ensuring that we're addressing that in a multifactorial way, because neither the NHS or the local authority or the BCSE sector can do that in isolation. So part of the neighbourhood health offer is to make sure that we're working together and we're incentivizing for the first time areas based on need, not on a one-size-fits-all, which is very, very much around how the NHS has been commissioning in the past. And that leads to the next step for us as ICB commissioners, which you will hear in the next paper, is that we move in towards strategically commissioning, not just commissioning based on a service gap, but commissioning on what the population data sets actually says that population needs. Thank you.
Thank you, everybody, for your presentation. I'm now opening up questions to members. Councillor Simon.
Thank you, Chair. I've got one technical question, and then if you'll indulge me, a kind of more ward orientated question. I've read this report 3 times, and it's full of acronyms, and I know that that's the way life is. But I have not seen what Core 20 or Core 20 plus 5 means. So if you could explain what that is, that would be helpful. And then in the report, you talk about neighbourhood hubs. You talk about community-based teams. You say that Moulscombe, Whitehook, Hollingbury and Woodingdean are identified as areas of particular deprivation and complex health needs. But then on page 44, when you're talking about the integrated community teams, it says, in the west of the city, the local health forum has been delivering community health days in Hangleton, Marloke and Knoll. The east ICT has established the East Community Health Hub in the heart of the Whitehawk estate, with satellite models working into Bevendine and Moulscombe. And Central ICT have been supporting existing community hubs in the Hollingdean, Hollingbury and I'm assuming that says Tarner areas of the city. And I'm not seeing Woodingdean mentioned there, and that's where I'm from, and that's the residents that I answer to. So my question is all this outreach, neighbourhood outreach, really equally accessible for all those identified areas of health deprivation and complex needs? And if these services are available to residents, how can we find out what's available, where it's available, when it's available, genuinely in our neighbourhoods? Because it is a couple of buses to get to Whitehawk from Woodingdean. So that's a very specific sort of ward-related question as well there. Thank you.
I'll answer the Core 20 plus 5. Apologies for the acronyms. Noted. Well, thank you, and apologies for that. Core 20+5. So Core 20+5 is an NHS approach to addressing inequalities, and so the Core 20 part is about those people who live in the decile 1 and decile 2 of our population, so our most deprived population. The plus part of the term is looking at our inclusion groups and making sure that we pay attention to those people who are inclusion groups. And the 5 part of the term is that there's one for adults, and there's a separate one for children and young people, and each one has 5 clinical priorities we must pay attention. And those are considered the most important priorities to pay attention to if we're going to address inequality. So I apologize that wasn't described in that very much. In relation to the neighbourhood, do you want to take that, Tanya?
Thank you. In relation to the neighbourhood, these were just some examples. So Wood Dean is absolutely included. So in the city, we have 3 neighbourhoods, but 1 citywide multiple compound needs, because we know that people with multiple compound needs are across the whole city. But we have some specialist providers like Arch for homelessness, the Rough Sleeper program, Changing Futures. We've got our partnership trust, Mental Health Partnership Trust has a homelessness team specifically dedicated to the city, and our Sussex Community Trust, or SCFT, has a specialist inclusion health team, again dedicated to those communities that we know have underserved needs in the city. In terms of the ICT, so the 3 neighbourhood areas we have is east of the city, so East Brighton. We have the central of the city, and that goes up north as well. And then we have the west of the city. So we have 3 specific neighbourhood leadership teams. Each of those neighbourhood leadership teams have health forums. And those health forums bring together partners across health, care, voluntary sector. And that includes the local authority, so adult social care, housing are included within that as well. We then have patient forums that feed into those health forums, and those patient forums are made up of either patients on the patient participatory group for GP practices. We have community forums already set up, so we have LGBTQ+, we have a trans community, a patient voice, we have people with lived experience as part of lived experience groups. We have the Common Ambition, which is a dedicated commissioned voluntary care sector partner who does the lived experience piece, particularly working with the homelessness community. So all of those community voices feed into the health forum. And what we tend to do across each of the integrated community team is to address the priorities that are coming through the patient, but also from the data that Joe mentioned earlier. So each of those teams have a list of screening data, CVD, so cardiovascular disease data, emergency admissions data, mental health data, and it goes from immunization from children and young people all the way to adults, and frailty in terms of some of the frailty factors. So each of those teams are meant to know the population needs and know where the highest needs are and address priorities around those. The first thing I will say, though, is many of those teams are coming together by osmosis. It's not formally commissioned as yet. So the commissioning piece that we have done from NHS Sussex is that we've commissioned what is called a Neighbourhood Health Alliance. And the Neighbourhood Health Alliance is made up of Community Trust, so Sussex Community Trust, Sussex Partnership Trust, so the Mental Health Trust, Primary Care, so all the PCNs, GP practices in the city, and they're working alongside the local authority, so they're developing memorandum of understandings with the local authority, because we recognize, again, we cannot tackle health without tackling some of the wider determinants of health, and also with the voluntary sector. In the ICB, we have commissioned what is called the Sussex BCSC Leaders Alliance, which is to mean that we have BCSC leaders across East Sussex, West Sussex, and Brighton and Hove coming together, and they provide a lot of the infrastructure, BCSC sector provision, so they support smaller grassroots BCSC organizations to have a voice on the ICB programs, service redesign programs, transformation programs, service reconfiguration programs, and even commissioning of new service programs. So we tend to use all of that wide sector voice to drive the changes around the neighbourhood health. So hopefully that answers the questions, but Woodin Dean is absolutely part of that. In terms of the delivery and what is delivered now, is we have commissioned neighbourhood mental health teams. That's part of the ICT. So we have 3 teams in Brighton and Hove that specifically provide mental health services to all of the citizens, residents of Brighton and Hove. And that is through those neighbourhood mental health teams. They have specialist psychologists, they have well-being champions, they have commissioned services from South Downs, UOK services, so VCC sector partners, who will run hubs, they will do informal talks, they will do informal, I think they run well-being hubs as well in the city. Preston Park is one of those areas. Although what they're doing now is to try to align to the neighbourhood health teams so that we don't offer sporadic, patchy, disjointed services in the city. So that's the aim of the neighbourhood health model, and that's what we hope will be seen. So GP practices will continue to deliver GP practice services, but now they have SCFT around the table, community trust, mental health around the table, and/or adult social care as required, and VCSE sector partners. So what we're trying to do is coordinate people's care better in the city through those integrated teams. And they start small, but they will grow over time.
Can I go? Thank you. So it's a work in progress. Everything is, right? And so in terms of delivery, so if I'm completely honest, I don't still feel clear. In terms of delivery, like what you're talking about are hubs. These are physical hubs, aren't they? Right? In various parts of the city. And and I'm quite happy if you don't want to answer it. I'm quite happy to kind of take this kind of onto email if to get some more specific information. But what my residents are, because we're kind of we're a very specific geographical area, kind of very much tacked on the outside of the city. It's very easy for my residents to feel left out, underserved. And I want to either be able to tell them that that's not true and prove it, or if it is true, I want to change that. So maybe I need to have an email conversation with you about it so that I can really understand exactly what's available to them, exactly how they're being served. And so, I can kind of work with that. So maybe that's something we need to do separately. Thank you.
Absolutely. We can take the wider context offline, but just to reassure that the delivery is, although starting small, what you should be seeing now is those persons with multiple complex needs have a designated MDT coordinator, so they will have a coordinator. So again, we can pick up the service that's in Wood Indeed, but it is part of the East Brighton ICT. And so we need to just ensure that you're assured your patch is covered.
Thank you, Councillor Simon. Jeffrey? No. Mary?
Thank you. I have a background in health and social care, and I found this report very dense to read and understand. I think if that report is written for this generalist audience and for the public at large to access, and it needs to be written in plain English and the acronyms explained. I did glean from the report that 21% of older people in the city are living in income deprivation, and that has consequences for their life expectancy and higher rate of multiple long-term conditions. And at one point in the report, it says that the Ageing Well programme supports older residents at risk of poverty, frailty and isolation. I would warrant a fair bet that most older people in the city don't know about the Ageing Well programme or what they can access via that programme. Older residents report to us difficulties in making appointments with GPs and dentists, difficulties in travelling for hospital appointments across the county, poor experience of subcontracted transport arrangements, long waits for treatment, and great frustration with automated and digitised systems. How are we to square this with the picture presented in this report? In what ways are the needs of older people being better met by what's being explained here? Thank you.
I'll start off and then I'm sure Nikki will come in. So the Ageing Well Partnership is commissioned jointly by Public Health and the NHS, and it offers a myriad of services across the city. There is a single point of access for older adults, and they can ring that single point of access, and it is shared by the VCC sectors, cascaded through, hopefully through communities. We've cascaded leaflets to each groups that we know about are run in community centres, community groups that are run through those community centres and or through the mosques and other faith-led points of contact. So hopefully would have gotten to most, but I agree there are many people that it potentially has not reached. We've also cascaded that through care homes to relatives and families to ensure that that information is accessible. It is on our websites as well as our external internet points. There is that single point, as I mentioned, but they're also doing targeted outreach to certain population groups, and we mentioned those health inclusion groups earlier on, but we also mentioned we haven't mentioned yet the very elderly, so the 85 plus, that we know many of those are either housebound or are less active and therefore may not socially come into contact with other persons who may obviously know about these services, and or their social isolation we know is also arrived in the city. So there are befriending, there are well-being groups, there are obviously advice around finance and benefits. There are in some areas like in Whitehawk, I know the VCSE sector, I've forgotten their name now, but I'll remember shortly, they do a house-to-house. So they do also do, befriend a neighbour, and the neighbour knocks on the doors in that neighbourhood and say, have you heard about the befriending service? Have you heard about the wellbeing groups that are held in the community centres? And if people can access those groups. There is no limit to age in terms of tackling that sort of access to services. But I don't know, Nikki, if there's anything you wanted to mention particularly, but I agree there might be people that are not aware of how to access those services. So we can certainly share with you the single point of access and that contact detail.
Thanks, Tanya. I would really value a conversation to listen to what you think about the Ageing Well and see what changes we can make immediately, because that is a worry. It's a really small team, and some of the work obviously is focused on falls prevention, because that's the most disastrous event that can befall someone who's frail and elderly. But I would love to meet with you and hear what you think, not just how we publicise the team more, but how we can do more preventative work as well with adult social care colleagues.
Councillor Parrott.
Good evening. So I had a couple of comments. Inequality is runs through every presentation that we have virtually in HOSC, and I would say in just everything. Everything I touch feels about inequality. So time and time again, we're hearing about the impact and significant impact in this city, particularly when you look at some of the issues that we are dealing with, some of the, the prevalence of some of the groups that we have, and the impact that we're having, the rise in mental health, etc. So I guess my question is, one of the things that always feels missing to me, and this report was incredibly dense, and like Mary, I am not afraid of reading these reports or going through them, and it mind-boggled me. And I also work in the sector as well, and I understand most of the acronyms, so I have no clue how anyone coped without an understanding of the acronyms. So I think, we could do with a bit more work on that. What really concerns me, and what I couldn't get a handle on, was the trends. So what I'm struggling to see, there's figures everywhere flying around, but what I'm really struggling to see is the overall trends, so that we can start to work with and identify where trends are rising, where they're falling, why, if they are falling, fabulous, but why are they falling, what's working, what's not working well. If they're rising, okay, maybe not so great unless it's a good trend, but most trends are bad. So and again, why? Let's try and understand that. So without trends, we can't really understand what's going on. We see figures in isolation, and they don't really mean very much without a full set of background data. So I would be really interested to see more work, more understanding around trends and what they actually mean. My other thing is we're very, very, very reliant on the VCSE sector delivering. Now, I have nothing but admiration. I work very closely with some of our big commission partners in the city and some of the other, some of the smaller grassroots people who reach out to me with my lead role in disability and VOG for the city. So, people reach out all the time, and some of these groups are delivering above and beyond in multi-complex areas where they probably really shouldn't be, but they are, and they're getting stuck in and doing really, really great work. One of the things I consistently hear, though, is that, most of these charities are very reliant on funding. They're either out constantly searching for funding, which is, a task and a job all of itself. We're not supporting them in doing that. But equally, they're getting pots of money from us at Brighton and Hove, they're getting pots of money from the ICB, they're getting pots of money from Sussex Partnership, pots of money from Sussex Community, pots of money from the NHS. And one of the things that concerns me, and we've all seen charities, some high-profile charities that have gone under or gone bust, because we are asking people working in this sector to do quite complex jobs of fundraising, managing quite significant, reasonable sums of money, employment, and a lot of other things that are actually quite complex and quite difficult to do. And they maybe started off in somebody's back bedroom looking after, somebody, quite a small area, and it's grown and it's grown. So my concern there would be around how are we checking the commissioning and understanding what's happening and the service and the quality we're getting back for that. We are very, very exposed to VCSE sector. If anything goes wrong in that sector, we're in trouble.
I think Steve. Probably if Steve wants to come in.
Yes, Steve, do you want to come in on that?
Yeah, thank you, Chair. Thanks, Councillor Parrott. I love your questions. That's fine. I mean, I think in terms of just building on what Tanya and Nikki have talked about, I mean, the report on the health inequality data across the city is really an attempt to say we've got a limited resource. We know that we've got real pockets of health inequality across the city. And therefore, what we're trying to do with the review of the health and wellbeing strategy that Tanya talked about is we've got to try and target those resources in a different way in the places most in need. Now, speaking to the voluntary community social enterprise sector, you're right, they're often the backbone of lots of our communities. They're close to the communities that we work with, and so often they're more flexible and they're better at engaging with communities than big old rumbling statutory services are. We know that we're under pressure, and I think our relationship with the VCSE, certainly under the review of our health and wellbeing strategy, is to focus as much resources as we can into that part of the sector. So when we talked about integrated community teams, lots of the leadership around those teams are led by the VCSE. So we've got, as we've said, Hankleton and Knoll in the west, the Trust for Developing Communities in the east. And I suppose this is a conversation focused around adults, but the health and wellbeing strategy is around all ages. And yesterday there was a presentation at our corporate leadership team around our youth strategy and our youth culture strategy, which again focused resources on our VCSE in the east and west of the city. So I suppose by way of assurance, we are aware that the best delivery partners for communities are often our VCSE colleagues, and so we're very focused on making sure the resources get to that part of the sector. We've only got a limited resource, so it's very much around focusing as much as we can.
To be clear, I wasn't criticising them or the work they do. Quite the opposite. My point was around how we support them to make sure, because as they grow and are being asked to manage in an increasingly complex world, so therefore we're asking them not just to be engaging with communities, we're asking them to manage financial budgets, we're asking them to manage resources, we're asking them to do a lot of things. And there's a lot of statutory obligations they have to fulfil around employing people, etc. Those are the kinds of things that we're asking them to do. I'm not questioning the majority. I'm not going to say everyone, but I'm absolutely not questioning the majority of them, their competence and their ability and their unwavering commitment to reaching out into the community. I need to be very clear about that. That wasn't what I was questioning.
Yeah, sorry, I probably wasn't clear. I never thought that you were. I guess what I was trying to give you assurance about was that our work with them and our reliance on that sector is based on the fact that we need to promote that sector and make sure that if we are going to fund through grants and contracts, that there are those sort of infrastructure costs built into those contracts. So I think we're on the same page.
Tanya.
And just to add to what Steve has said, that's the reason that we have commissioned the SVLA, or the Sussex Voluntary Care Sector Leaders Alliance, because we recognise there's so many, and some are very small, single-led, sometimes with 2 or 3 members of staff, and very vulnerable, but provide such an essential service. We have funded both the local authority and the NHS infrastructure, so that means they grow what we call the back office functions, and they do that on behalf of a number of VCSE sector partners, but they obviously would need to join that infrastructure. So in Brighton, for example, you have an infrastructure organisation, and the part of the function they provide is finance, budget, and recruitment support if needed for VCSE sectors who are members of that infrastructure organisation. And the VCSE sector, the SVLA, so the Sussex Leaders Alliance, is meant to look at all the issues, the problems, and be that single conduit, not just in terms of vulnerability, but identify where we have grassroots VCSEs that we are just happy doing what they're doing it very well, but we don't know about them. So some of the challenges for us is to ensure that, one, we support VCC sector partners that we commission, and we are jointly Public Health, Local Authority and NHS working together around commissioning, better now than we have been in the past, and you're right. We put a little money from the NHS here, we put a little money. We are working with the providers as well to ensure that we're not duplicately commissioning a service, but that we're commissioning a service over a number of years instead of 1 year at a time, which previously, as you would accept NHS funding, has always been 1 year. We now have commissioned all our VCSE sectors, and we have committed to a 3-year contract, which helps with workforce and planning in terms of service delivery. So we're doing some things differently over 25, 26 and into this year that we've never done before because of the vulnerability you mentioned.
Councillor Evans.
Thank you, Chair. Thanks for the report. I mean, not that I disagree with the comments about density or acronyms, but density and acronyms notwithstanding, there's a lot of very positive stuff in there and a lot of clearly good intentions about reducing inequalities. However, I want to ask a small question about a little area, but I think it's important, which is, I know a local practice who's stepped in at a point where to provide healthcare in one of the most deprived communities in the whole of Sussex, top 10 in the country, when the previous provider had pulled out, leaving residents in the lurch, and within a couple of years they had addressed all the kinds of things that we're talking about in this report. They'd expanded the patient list from 4,000 to 8,500, patients. They'd hit the targets for hypertension testing for the first time. They'd managed a 33% reduction in opiate prescriptions, even though patient numbers had nearly doubled. They'd upped vaccination rates from around 70% to over 90%. They provided social prescribing, they formed relationships with local schools to provide health prevention education and access to a community garden. They built trust with the community that had been let down over and over again and who have a really nearly 10-year difference in life expectancy than richer areas only 2 miles away. And their reward for all of that exemplary practice was to be under threat of losing that contract to a for-profit provider, and that for the last, I think this is their 3rd year now in a 1-year contract extension, which makes their continued practice all the harder when they're presumably all under enormous stress that they're not going to have a job next year. And I just really, I mean, that's a comment and not a very happy comment, but when we're talking about all the good stuff in this report and all the good intentions to reduce health inequalities in this report. And we're talking about strategic commissioning and how it might help us do that. And I'm just, I guess, wanting some reassurance that we won't hear stories like that going forward, because I don't see how that story, which is a very recent story and a still ongoing story, fits with any of the good intentions in the report to actually make a difference to the health inequalities. Because here is a group of people who were doing just that, and who, for reasons none of us really understand, were almost out on their ear.
So
Don't you want to comment on that?
Yeah, just a comment. In terms of contracts, we won't go into the ins and outs of that specialist situation, because that is still undergoing an investigation due to be published, I understand. But I think there are two elements. So GMS contracts, and that's general medical contracts that we commission. So there is still provision around the general medical contracts, so the overarching GP services. What I think is being referred to is an APMS contract, which is additional services that we commission through primary care. And that is the one that's under investigation. So just to assure that the general medical delivery still continues in that area, the additional services, as my colleague has mentioned, councillor has mentioned, that is going through that investigative period. And yes, the aim is to ensure those APMS contracts address health inequalities, but also drive up population outcomes where there are high multiple long-term conditions, where there are other health inclusion groups, etc. And that funding is very much driven around a formula and is very much fixed. And those are APMS contracts when you look at some of the national. However, in terms of the contract referred to, that underpins the delivery of some of those community services. And I agree with you in terms of what we now need to look at is how the neighbourhood health teams, and once that contract is re-procured, works together to deliver better health outcomes, building on some of those outcomes that you've mentioned before for those communities. But I can't speak specifically to the provider concerned in that process.
Thank you, Tanya. Marina.
Hi, thanks. Hi, yeah, I'm just kind of interested in specifically neurodivergent children going to school. You mentioned in the report that they particularly face kind of quite stark inequalities. I noticed that in the report they kind of seemed a little bit tagging with afterthought. Neurodivergent was mentioned a couple of times, not really expanded on. So I'm just wondering, what is the approach to kind of identifying the unmet needs of neurodivergent people who often just give up at the annoying ring of music of phones and try to access services? What's been identified so far? What are the plans for improving that? And also just added on to that, I think it connects to the kind of the lived experience approach. What is that? And can you expand a bit on how that's going to work? So two questions basically about neurodivergent children. What's been identified in terms of unmet needs? What's being done? And lived experience. And also, I guess, if I kind of had to ask the third, homelessness, always going up every year. How are you expanding capacity to meet growth on homelessness?
Thanks, Councillor. So I'm new to the area, but certainly neurodivergence in children and adults has been something that's mentioned both in the context of serious mental illness, people having both, which is really interesting, and also people with neurodivergent issues self-medicating in the context of drug misuse. So it's been mentioned in every forum that I've been in, and I started at the end of November. I think we do need to do deeper work. I don't think including it here, it wasn't meant to do it justice here. It's been mentioned, but we need some proper work on it. There is a special educational needs assessment currently being done, but I am planning a separate piece of work on neurodivergence, but we usually do that separately for children and adults, and that should include lived experience. And in terms of homelessness, again, a really big topic. This wasn't meant to sort of cover everything. There's a lot of work being led by the housing department, but there is a lot that can be done. So, for example, high proportions of our homeless residents who are either rough sleeping or in hostels have dual diagnosis, so they have mental illness as well as drug misuse issues. So there is a lot of positive stuff that can be done and can be changed.
Yeah. There's such huge overlap as well. The rates of neurodiversity in homeless populations is way higher, and in the city, I think it's 13% are neurodiverse, which is way higher again than the national average. So, also, how are you going to go about reaching out to neurodiverse people? I mean, I was thinking Queen's Park. So many live alone in the ward I represent. So, how are you actually going to be identifying and reaching out to neurodiverse communities who so often aren't able to actually find the very people that are trying to kind of gauge what their needs are?
Sorry, Councillor. Just to explain, in terms of public health, I don't directly do outreach, but I commission services. So I'm responsible for substance misuse, health visiting and school nursing, and sexual health and family planning. But I do have a partnership role with mental health services in terms of Sussex Partnership Foundation Trust, so SPFT. So in terms of the outreach, I'm not able to answer that now, but in every discussion that I've had with doctors and nurses at SPFT, neurodivergence has been mentioned. So I'd be happy to discuss that further. I don't have the answers here, but
I'm going to go to Stevie.
Thank you, Chair. Thank you, Councillor. In the council and in the city, there's a very active autism partnership board, which is driven by many people who are neurodiverse with lived experience. And so we will be working very closely with boards such as the Autism Partnership Board on the development of services, getting the input and the co-production from people with lived experience there. So it was mentioned here that there is a much bigger programme of work going on for our neurodiverse community, and we work with that partnership board around lots of engagement work.
Can I just add that actually I sit on the Autism Partnership Board and it is absolutely fabulous. They work really, really hard, and there are many, many VCSE sector partners on that board who work together with, and it is genuinely one of the best co-produced boards and partnership strategy boards I work on. I just can't speak highly enough of it. It's amazing.
Thank you, Councillor Parrott. Councillor Mackey.
Thank you, Chair. My question corresponds with Mary Davis from the OPC and also Councillor Parrott. With regard to VCSE contracts, I was at a Trust for Developing Communities meeting with GPs, community engagement teams, and VCSE providers, looking at mental health provision in the contracts. And what really struck me was that the contracts for mental health support only went up to the age of 65. And I asked the question, why is that? And they said, well, that's just the contract. And I said, well, people over the age of 65 suffer, also are vulnerable to poor mental health and need that provision. And people don't retire until 67 now. So why is that arbitrary cut-off point of 65 for mental health support?
Should I? So I think there are a various number of VCC sector partners who are commissioned for various things. So South Downs and UOK are commissioned for older adults, but there are also VCC sector colleagues who are commissioned by the Sussex Partnership Trust, particularly the Mental Health Trust, for children and young people. So I don't have a list with me today, but I could certainly look at that list and send it back through Giles to share with the council. But there are different commissioning for VCC sector partners across the whole age range. But yes, for South Downs and UOK, there are a certain age group that those services are commissioned for. And that's part of the adults' mental health and well-being pathway. So there's a separate one for the children and young people pathway.
Do you want to come back, Councillor Mackey?
Yes, thank you for that. That would be very helpful if we could have that information. I just had a subsequent question on malnutrition across the intergenerational malnutrition, but the increase in hospital admissions for people with malnutrition and how people suffering with that, it's holding up them being discharged from hospital, and therefore it's costing the NHS significantly more with every day that they are staying in a bed because they do not have any provision, whether it's Wheels on Meals or whatever, to actually help them on discharge get nutrition and feed themselves. I wonder how much that's being taken into account, because I didn't see anything in the report on malnutrition and its impact in relation to inequalities.
Wait a second, turn your microphone. Thank you.
Thank you, Councillor. And just to add, there is an eating disorder specialist commissioning, and that's done through Sussex Mental Health Trust. So we can certainly get more information and come back. In terms of looking at the whole pathway for persons with malnutrition, which obviously will affect all ages, but mostly some of the vulnerable older adults. But we also have a variety of different eating disorders that do cause challenges with discharging, both from children, young people, and adults as well. There are specialist pathways that are commissioned through specialist commissioning, so we can certainly look at that. I mean, I don't foresee I've got the answer. It wasn't included in the report, and we didn't particularly look at malnutrition in terms of the data, so we could probably go back and check on that. We do know in terms of eating disorders and self-harm, there's a link between some for the younger groups, but we certainly didn't look at malnutrition as a separate piece in terms of inequalities.
In relation to malnutrition, we do look at low birth weight at child, which is sometimes in relation to maternal low malnutrition, which is a concern for us. But what comes out really at the numbers level, which make us have the impact, is more about obesity in relation to inequalities. Doesn't mean malnutrition isn't, but it has improved. That's probably one of the things over the last 100 years that has improved. But that's probably because it doesn't get onto my radar, really, because the numbers aren't as significant for us to have that much concern. It doesn't mean for individuals that's not the case. So I think that's why you're not seeing it here, because it's not an issue that's really driving inequalities in this area. It doesn't mean it's not prevalent. It just means it's not at a level that's impacting that more. But obesity is one that is in relation to children's health. Are you talking about children specifically or wider? Because we could look at that further. Oh, sorry.
I was talking intergenerational, but I was referring specifically to older people in hospital. But it may not be a driver of inequalities, but it is a result of inequalities, surely.
It can be, and you're right, it would come under our frailty strategy, absolutely, in relation to others. Apologies, I was thinking about younger. But you're right, absolutely, in relation to, it's probably an indicator of frailty, fragility.
Thank you. I'm going to bring Nora in, who's online. Nora.
Well, I hope the connection is a little bit better than earlier. Thank you for the presentation. I just wanted to find out if there, as we know, there is a link between health inequalities and access to open space for leisure and exercise. Is there a plan in place to make spaces more accessible? Again, looking at like low cost and free access to gyms. We know also the cost of travel has gone up, and that obviously has an impact as well, and stops people from being more active outside of necessarily of their own area, especially when people trying from some areas trying to go to gyms that are not in their area, they will have to travel. So that would be my question.
Thank you very much. So Brighton and Hove is one of the most physically active areas. There's been a lot of investment into physical activity, walking, let's get moving. You may be familiar with some of those. Some are targeted at people with mental health issues, some are for older people, and some that are schools-based on children. So there's a lot of work happening in the city which we can share with you. Thank you.
Councillor Winder.
Thank you, Chair. I wanted to ask kind of quite a big question, which is based on one of the best pages in the report where it says health inequalities are not inevitable and gaps are not fixed. That page really seems to say what's the journey that you want to be on and what would we like to see from that. So it's kind of how do we pull all this together, which seems a little bit fragmented at the moment, into some really ambitious one city approach so that we don't have those pockets of deprivation everywhere that we don't quite understand, and then the other areas where we're not sure what to do about these things, and how does it actually evolve into something that feels positive and good for the whole city to believe in.
Sorry, thank you very much, Councillor. So this report wasn't intended as a plan or a way forward. It was more a statistical snapshot. So you're absolutely right. The next part is what Tanya referred to, which is a refreshed health and wellbeing strategy. And that hopefully will look at all those important, we call them wider determinants of health, like housing, employment, green spaces. That will be the plan. This is just the statistics bit. So thank you.
Follow up. I just wondered how you actually involve the people that need this support in developing the outcomes that you want to promote and develop.
I mean, we will be co-producing the strategy, so we're drawing up a list of who will be involved. Hopefully it will be everybody. As many people that we can. And as Steve Hook and Councillor Parrott mentioned, we do rely a lot on the voluntary sector. We've done research as well with Hangleton and Knoll to build research capacity in the voluntary sector, and we're hoping to do more. So really happy to work on that.
And just additionally, we have now just about to commission for this year, 26-27, community engagement through the VCSE sector. That will be through forums and surveys and discussion points, but also we have Health Watch, and we commission Health Watch jointly with the local authority, who give us a lot of feedback from patient insight. So we utilize that in our decision making, and that will be utilized in the strategy refresh in terms of health inequalities.
Councillor Parrott.
It was just a very quick point, actually. I just wanted to be clear, following on from Councillor Mackey's comment about malnutrition. Malnutrition and eating disorders aren't necessarily the same thing at all and shouldn't be pulled together under a bracket. Obese people can have, obesity being potentially an eating disorder, they can have suffer from really strong malnutrition depending on, again, where they live and their inequality, but also elder people often don't have eating disorders. They just don't have access to or the ability to make good quality food. And the other question I wanted to ask was, we've got these hubs which are very centred, although they're east, west and in the north of the city, but they are all centred around the kind of top part of the city. We've got quite a bit of a dearth around the bottom half of the city, if that makes sense, the seafront part of the city. There's nothing there's nothing in Kent Town, there's nothing in my ward, which is in Hove, so there's nothing very much in Hove. And actually, one of the major problems we have with transport in the city is getting north to south, getting east to west. You've got some really, really good bus routes and a train line that you can get north, east to west, but actually getting, from the south, somebody who doesn't drive, getting from the south part of the city where I live to anywhere in the north part of the city is a nightmare. I had a resident ring me and asked me to go and meet them at Withdean to talk about parking bays, which was lovely. I had to get a taxi. The thought of getting a bus there was just like more days than I had in my life to spare. So, I'm lucky I can afford that taxi for that. But, that's not a convenient solution if that's where you've got to go for a hub. So it's a question really about how we're making sure we've got access, because whilst those aren't necessarily the most obvious deprived places, in my ward, for example, we do have some little pockets of extreme, where there's still people with extreme deprivation. It isn't, I know that I know there's a huge focus, and I really understand that, and I wouldn't take away from those areas. That doesn't mean we don't have people really, really struggling with, inequalities in some of the other parts of the city. My ward looks on the surface to be gorgeous. It's Westbourne and Poets Corner. don't tell them I ever said anything different. It's a lovely looking place to live. There's huge deprivation in certain little pockets in there. We're not without our issues and our problems.
I just want to say that's a good challenge actually about malnutrition. So apologies for I was more thinking about weight and how we can. I was thinking about how we can measure it really. But that's a good point about you might be obese or considered to be obese, but it doesn't mean your nutrition is good. So thank you. That'd be interesting. An indicator we could have on that actually. We can give that some thought. Generally go on weight. That's important. Yeah.
I'm not sure if anybody wants to come back on the question regarding the hubs and their location.
Sure. So regarding the hubs, and this is a evolving picture, so it's not the end point, it's the start point. So I just wanted to reiterate that. And yes, we're starting with the areas with the greatest deprivation and the greatest population health outcome in terms of need. And looking at the ICT dashboard that Joe referred to for each of the 15, so the 3 in Brighton compared to East and West Sussex as well. But it doesn't mean that there won't be hubs where there are none now. So I think there might be a different hub and they might focus on different things. But we have to start small, and we're trying to build from an assets-based approach. So what do we already have and how do we build on top of that? So certainly Hove is not going to be left out of what's to come.
Thank you, Tanya. Jeffrey.
Just thank you for the report. I mean, I will echo what others have said. It's extremely dense and peppered with acronyms. And in terms of communicating clearly, I do recommend you talk to the Patient Information Forum. It really does help to get what you're doing out, because there are gems in there, but you have to dig and redig and put a microscope on there to find out exactly what you're saying. But just a comment on access, I may be chair of Health Watch. I'm also chair of something called Friends of Queen's Park. I've been trying for about 8 years to get some railings reinstated on a very steep path, which elderly people find and people with mobility issues. So the question is, come up with a strategy. We're in budget setting mode in the council at the moment. Is there any money to actually make access for vulnerable people to open spaces, gyms and so on? Is there going to be any money to back up the aspirations of the strategy when it's published? Maybe above all our pay grades, but if I can't get some railings reinstated on a very treacherous, steep path into my local park, what chance elsewhere in the city?
If you send me the park, I will speak with Parks. Thank you. Queen's Park, you said that's fine. I will take that away. Thank you.
Thank you, Jeffrey. Do I have any other indications from members with any questions? I can't see any. I'm going to ask a couple of myself in my guise as chair. We're looking at reducing health inequalities in Brighton and Hove, and I guess one of the key risks in doing that is that we have a lot of activity, and there's a lot of activity in this report, as has been mentioned by the members. But we could end up with a lot of activity without measurable narrowing of gaps. That is a key risk. We do a lot, but we're not actually reducing that gap. And I guess, questions that come out of that through the report are, we talked about some widening gaps. Are there any that are narrowing in there? And a point that was raised earlier by Councillor Parrott was one about trend lines. It's about measuring whether those gaps are widen or narrow. And I think that's crucial to reports such as this. They give a very good snapshot of where we are, but they're not projecting. And I know the work's coming in stream, but as a committee, we want to see that progress is being made in terms of trend lines. So I guess, in conclusion, what I'm saying is I recognise the breadth of work that's being done, and there's some amazing work being done. But I think the test is whether we do see narrow and measurable gaps. So I'd like to recommend to this committee, or if you're willing to agree yourself without going through a recommendation, that at least annually we have a Brighton and Hove Health Inequalities dashboard come before us. to be presented to HOSC. One that will cover the key outcome gaps that we talked about today, such as life expectancy, long-term conditions, screening updates, mental health indicators, housing, aging population, child health, mental health in young people. So we can see from that dashboard the trend direction over time. I think that's really crucial as a committee that we have oversight of that, and we can see where gaps are widening, and we can see why. That's fundamental to this committee to scrutinise this work. So if you're on Greens to do that, then we don't need to make a formal recommendation. But if that's not something that you have on your work plan, then I'd like to make a formal recommendation to committee to consider that. Thank you. Please.
Yeah, I was just going to say, those trends are available on the public health outcomes framework. We didn't bring it here, but we can. That would be absolutely fine. And they have a red, amber, green system, which show things that we are trending better at, things that we're trending amber, and things that are red. And it is very user-friendly, so happy to bring that back, noting Councillor Parrott and yourself.
Thank you very much.
Sorry, I'll just add the areas of concern are based on trends, so that also is on a dashboard which is electronic, which we can share as well in some fashion.
Okay, then if committee's in agreement, I will make that formal recommendation, and I'll just ask that, are we happy to note the report? Thank you. Given the time, we have one more agenda item, which is a standing item. I'm going to take a very small 5-minute comfort break before we bring that report back. What I will say is, as this is a standing update to the committee on recent and upcoming service changes in the NHS locally, my recommendation is that we can just note this report rather than going into the depth of it. But if any member has any important or pertinent question to ask, I will offer that opportunity. So maybe reflect on that in the 5-minute comfort break, and then we can consider that when you come back. Thank you. Final substantive agenda item, the NHS change. As I mentioned just before the comfort break, this is a standing item coming to the committee on recent and upcoming service changes in the NHS nationally and how they impact on us locally. I've made the recommendation to committee members that we can just note this report unless any members have a particular question they want to ask. Can I see any indications? No, in which case, does the committee agree to note the report? That's agreed. I didn't think there would be many objections. In which case, I will now call the meeting to a close and thank you all very much for your attendance and for staying to this late time, and wish you well upon the rest of your day.